So good afternoon and welcome to the third Move to Value Nursing Series hosted by Chess Health Solutions. My name's Thomas Royal. I'm the Director of Marketing and Communications here at Chess, and I'll be your host today. This is a virtual event focused on the most critical members of the healthcare team, the nurses. So for those of you who don't know, Chess Health Solutions was founded in 2012 by a group of physicians in North Carolina. We are a physician-led healthcare services company empowering clinicians and health systems to make the transition to value-based medicine. And you can find more information about us and all of the things we do at chesshealthsolutions.com. So you may want to follow us on our social media channels and join the conversation today using the hashtag Move to Value Nursing Series. And let everyone know you had an unbelievable time. Oh, thank you. Thank you. I've been wanting to use that joke for months. Where was I? So if you have any questions or comments during this presentations, type them into the chat and we will present them to our speakers at the end of each of their presentations. And lastly, as a reminder, to receive North Carolina nursing contact hours, you must have a MyAHEC account with a current phone number on file. To create a profile, visit my.ncahec.net. That's my.ncahec.net. At the end of the presentations today, we'll show a session code that you must text to receive credit for attending. So if we're all ready to go, let's get started. So our first presenter today is Shannon Parrish, and she's the Director of Care Coordination for Chess. In her role, Shannon provides clinical and operational guidance to Chess value partners and direct supervision to the Chess Care Coordination Hub. She received her Bachelor of Science in Nursing from UNC Chapel Hill, and she holds her CCM certification. Shannon has 21 years of experience in nursing, 14 years in inpatient oncology and palliative care, and the last 7 years in the value-based care space with Chess. And she's one heck of a colleague. She is an alumnus of North Carolina's Great 100 and is passionate about equipping teams to have maximum outcomes for patients. Today, Shannon will share with us the importance of effective patient education and how to equip patients with the skills to advocate for themselves. So without further ado, please join me in welcoming Shannon Parrish to the virtual stage.
Good afternoon. Thank you so much for joining us this afternoon. It is my absolute pleasure to speak to you today around patient education strategies. I am a huge believer in the power of a nurse and the difference we make in patient lives. And so I am excited to celebrate you today and the opportunity you have to change the lives of your patients and to make a difference. And I think foundational to that is patient education. I had the privilege of speaking on patient education a few years ago, and as I revisited the current literature and what to speak on, there have been so many advances in the healthcare field and technology. But in patient education, the principles are foundational. What used to work still works. Some of our modalities are different in fact that you have now texting and video and FaceTime chat with patients, etc., which make the virtual education space a little bit different, but still foundational to changing patient behavior and impacting patient lives is the basic concepts of patient education. So it's my privilege. In today's agenda, we're going to talk about the power of education, the impact of health literacy, the learning needs of the older adult, and then utilizing teaching strategies. So, as we talk about the power of education, let's first start with the next slide here, defining patient education. So, patient education can be defined as the process of influencing or shaping patient behavior and producing the changes in knowledge, the changes in attitude, and the changes in the skills necessary to maintain or improve health. So nurses wear many, many hats, and whether you're in the inpatient world or the outpatient world, some of those hats look a little bit different. But one of my favorite and universal to nursing is the opportunity to be a teacher, and it is to educate. I know that my team really likes to see that we make a difference. We want to know that the work we do has meaning, has impact. And I think knowledge is power. It equips patients for success. And it's like tossing them the keys so that they set their own course for their health journey. It's empowering that patient to be in the driver's seat, to be in control, to know that their actions have a direct impact on their own personal health trajectory. So patient education encourages several different things: patient compliance, patient satisfaction, healthy lifestyles, and self-care capability. So let's first start with patient compliance. Some of you don't have your video on, so I can't see your faces here. Can we move back a slide, please? We're going to camp out here for a minute. So with patient compliance, I can't see all your faces, but if you want to show of hands or in the chat, how many of you need to know the why behind the what? I will raise my hand. I am a big have to know why I'm doing what I'm doing. I am a rule follower, but I need to know why it's a rule. And so I think a lot of times when we think about patient compliance, we really need to make sure that they know what they need to do and why they need to do it. And patient education is a vehicle that secures that. A lot of times when patients don't do the right thing and they're quickly labeled as non-compliant, if you trace it back, there are barriers, which we're going to speak to later, or there's a fundamental disconnect in their understanding of what they needed to do. So patient education empowers that patient to be compliant and to do their part in their patient health care. So patient satisfaction. I know in the value-based space, patient satisfaction is playing a much larger role in our quality performance than ever before. It has really become to the forefront of what we're measured against from a quality perspective. And this goes beyond good customer service. Did you have a good experience? Were you pleased with the outcomes? Patient satisfaction as it relates to quality is really involving the patients in decisions and empowering the patient as the decision maker. Again, it's giving them the keys to set the course for their healthcare journey. And equipping and empowering patients is a patient satisfier and will go a long way in securing their compliance and their success. Healthy lifestyles. So the old saying that an ounce of prevention is worth a pound of cure. And so often in the healthcare space, we are trying to cure everything, when if we could get ahead of the issue and prevent it, we'd be in a lot better place. And so I really believe that an ounce of prevention is a pound of cure. And as medical technologies have come so far, you will never escape that there is a tie to patient behavior, that there is a tie to diet, to exercise, that directly impacts your overall health. So making sure that we educate and equip patients on how to follow healthy behaviors and we cheerlead them in those healthy behaviors will go a long way. And then self-care capability. So I'm going to say a lot of old sayings. I must be an old soul because I tend to defer to these things that you've heard your whole life. But you give a man a fish and he eats for a day, and you teach a man to fish and he eats for a lifetime. The other thing that I think is really critical here is all of these things involve the patient. It's the patient's compliance, the patient's satisfaction, the patient's participation in a healthy lifestyle, and the patient's self-care capability. And so really what I want to highlight here is, and it's a big part of value-based care, is patient-centered care. The patient is the MVP of the team. They can have access to the best doctors. You can create access where they can be seen within an hour of their concern. They can have the newest medicines on the market. But really, if you want to impact a patient's health outcomes, you have to impact the patient's behavior. If they have access to the doctor, but they never go, If they have the right medicines, but they don't take it consistently, you're not going to have the same impact. And so I want to make sure that patient education is patient-centered and that we are taking into account the profound impact that taking that extra time to explain, to teach, to engage the patient in their own health journey will have on their overall health trajectory. Next slide, please. So let's think about what patients need to know. And there are so many things that a patient needs to know. So how do we prioritize the need to know over the nice to know? And the great opportunity that we have in value-based care is if you chronically follow and support these patients, once you get beyond the need to know, you can get to the nice to know. We have the time to pour into these patients and invest into their lives and their patient behaviors. But just foundational to take care of yourself, to stay alive, to stay out of the hospital, patients need to know the basics of their disease state. They need to know how to perform self-care, and that is diet, exercise, lifestyle, symptom monitoring. They have to know the importance of preventative care. They have to know the impact of their actions on how they feel. So sometimes we have to help draw that connection to patient behavior and the way they feel and the impact on their health. When I eat this way, I feel this way. When I don't take my medicines, this happens to me. They have to understand the direct correlation of their behavior on their health. But then they also need to know when to anticipate results. So you engage the patient, they're all willing to jump on this diet that you're having them follow or to take these medicines, but they don't feel any different in the first week. They quit. So you have to set realistic expectations of we need to do these things for this amount of time. This is when you're going to see the impact of these choices that you're making so that they stick it out for the long haul. Patients need to know the warning signs of what to do when there are problems and who you call. So one of the most important things you can do in every phone call is if you have questions, you call me or direct patients back to the office so that they know that we really want to direct the PCP as the main source of support for that patient. So us and the PCP working together are that support system for that patient. So when in doubt, call the doctor's office and ask questions and tell them how you feel and seek advice on what to do next. But when you're thinking about a plan for patients, these are the things that patients need to know. So I'm going to veer off the slide just for a little bit here. So I think one of the universal things that everybody likes, right? Kids, adults, there are a few major things. Chicken nuggets, mac and cheese, cheeseburgers, right? They're foundational foods that just about anybody likes and most people don't complain about. But while everybody likes a cheeseburger, everybody defines a good cheeseburger differently. So some people say, oh, it's all the way. Some people say absolutely full of onions, no onions, or I won't touch it. My daughter likes peanut butter on her cheeseburger. And so there are so many different ways. You wouldn't ever want to serve somebody a cheeseburger without knowing how they like their cheeseburger. Because you give them one full of onions and they hate onions, they're not going to eat it. So they still have an unmet need. They are still hungry. And even though you provided them something to eat, it did not meet the need and you still have the same outcomes. Education is not one size fits all. So if you start educating based off of everybody has to get this, this, and this, and you don't understand what the patient already knows, what their barriers are, what they prioritize are. If you don't have the context for their life to shape what they like, you're going to serve them something that's not going to meet their needs. They're still going to be hungry. So I want to make sure that we are asking these questions before we give answers, and we are truly trying to understand what a patient knows and what they need. And we're going to talk about that in the next few slides. So how many of you, this takes me back to my elementary school days, had field day and you had foot races, right? So you all line up on the race line, ready, on your mark, get set, go, right? And that's kind of the way they did it. So when we think about the nursing process, we're assessing, we're planning, we're implementing, and we're evaluating. So assessing is you're getting ready, right? I'm assessing everything I know to get ready. When I am set, I have my plan. And then when I go, I'm implementing. Okay. And so that's really kind of even just fundamental to the nursing process, but it applies directly to patient education. We need to assess the need and the opportunity, plan for it, implement it, and then we need to evaluate, was it effective? Did they like their cheeseburger? Did it meet their needs? Okay, that's what we want to come back to. So let's look at the next slide. So other parts of the learning assessment then would be to look at context, to really understand what's an ordinary day like for this patient. So how traumatic is this new diagnosis to this patient? Were they extremely active and now their independence is taken from them? Or were they pretty sedentary and this is not a big a big change on their daily life? What activities do they enjoy in their free time? Were they out hiking at the park? If so, then a hip surgery is going to have a tremendous impact on their mobility and their activity and their pleasure and their socialization. Think about how many times we ask patients to make diet changes. Well, if their activity, and mine, I'm a foodie, is going out to eat, how hard is it to follow a specific diet when you're out in a restaurant? So we need to think of the context of the life of this patient, because not every disease impacts the patient the same way. So we really need to understand what's an ordinary day like to you, what activities bring you pleasure, what is your family support like? You have really involved family, you're socially isolated. All those things impact what you need to know, the impact of your disease, and how you're ready to tackle that and what education you need. From a needs perspective, tell me what you understand about your illness. So don't start at A with everybody. If they've got A down, let's move on to B, C, and D. Let's understand what they know, what they need to know, and we're going to get to readiness, what they want to know. Okay, so what do you hope to learn about and what problems are you having? So let's let the patient set what they need out of that education opportunity. Then think about style. Do you learn best at a certain time of day? Are you fading fast in this after lunch spot? I think I got the post lunch coma before you get your chocolate chip cookies for snack. When you're learning something new, do you prefer to read it or hear it? And do you like to have someone with you when you're learning something new? And then from a readiness perspective, are you interested in learning? What are you interested in learning more about? And then all education, because it's shaping patient behaviors, needs to lead to action. We're not just teaching them so they know it. We're teaching them so they can act upon what they know so that it impacts their behaviors. So based off what we've learned today, what are you willing to work on? How do you feel about making the changes we learned about today? Okay, next slide. So once you've done that assessment and you have a foundational understanding of what the patient needs and where they're at and how to plan and make a plan to meet them, it needs to be meaningful. Can you relate it to familiar things or past experiences for patients? So if they have family members that had the same disease, and how did they watch them manage it? And what did they like about how they managed it or not like about how they managed it? What do they understand from what they've seen within their own family or their own health journey? Have they ever had to follow a strict diet? Have they ever had a major lifestyle change? How did they adjust to those things historically? Let's pull from what they were successful with in the past and bring that into future. But also from a meaningful perspective, it's speaking the language of that patient. So if you're speaking to a mechanic or an engineer, the body is a machine, and the way one part helps another part function the way it needs to, and the way they all work together to get to an optimal outcome. If I'm speaking to someone who loved to cook or a baker, then they understand following the recipe is critical. And I can't just pick the chocolate chips and the sugar. I have to have the eggs and the flour in my recipe. So I can't just pick my diet, or I can't just pick my exercise or my medicine. It's all those pieces of the recipe that come together to impact my overall success. So make it meaningful to the patient. Understand what their daily life's like, what language they speak, what is meaningful to them, and make your education meaningful to them. Meet them where they are. The next thing then is make it actionable. So what are the next steps? We will come back every time to prioritizing patient behavior and not just knowledge. It's what do they need to know, and then what do they need to do? If we go back to that original definition of patient education, it's shaping patient behavior. So we always need to make sure that our education is actionable. And then from relevant, what are they interested in learning? It's going back to that previous assessment and saying, what are your needs? What do you know? What do you not know? What do you want to know more about? What are you ready for? If I am not ready to make diet changes, talking to me for an hour about my diet is a waste of your time, my time, and your breath. We really have to make sure that, but if they are willing to exercise or they are willing to start checking their blood sugar, that's where you start. You have to know what they're interested in, and you meet the patient where they are. And again, this triangle, then we should have put a picture of the patient in the middle of it, because this is patient-centered education. It's taking that patient and making that education experience meaningful, actionable, and relevant to the patient. And then that garners patient engagement. So let's look at some of the barriers to learning. I think we've seen over the past couple of years, as we've started to look at barriers to health, like social determinants or barriers to health, we've learned quickly not to label patients as compliant or not compliant, because so many times patients want to do the right thing. And when they don't, it's not because they didn't want to, it's because they didn't understand, they didn't have the ability, they didn't have the resources. There's a reason behind it. So as we're making a plan and as we're assessing for how we're going to educate a patient, we need to understand what their barriers are. So from a health status perspective, if they're in the hospital feeling rotten, you got to seize the right moment to really make sure that that information is meaningful and useful to that patient and that they hear you. You need to consider financial factors. If you're trying to talk to a patient about a new medication and the importance of taking it, and all they're worried about is can they afford it, we have to address that first before we can then educate on the medicine. Think about then all the cultural and ethnic background and language barriers that can impact a patient. We're going to talk to it a little bit more in the presentation, but literacy, health literacy, comprehension, and the ability to understand, kind of draw inference and what to do next can be a barrier to learning. Poor support systems. So what if they are all alone? Or what if they are the caregiver for someone else in their family, and this is the first time that they've been the patient and had to be taken care of themselves? So we need to understand all these barriers as we make a plan for how to educate and equip the patient. So one of the barriers I want to spend some time on then is the impact of health literacy. So personal health literacy is the degree to which individuals have the ability to find, understand, and use information and services to inform their health-related decisions and actions. It's not one of those things. It's not can they find it. It's not do they understand it. It's can they find it, understand what they found, and use what they have found. And all those things make up health literacy for a patient. 9 of 10 adults lack health literacy to manage chronic healthcare issues. And when you think of the older adult population, which so many of us support from a Medicare standpoint, in adults greater than or equal to 65, it can be as low as 3% of the population And I think so often we have to check our own personal bias. So we already from nursing school, from personal practice, have all this education, and then we're running all that through that filter, right? But we have to understand if they've never been exposed to it, it's the first time they're hearing it, and they're hearing it when they're scared because it's a new diagnosis. Then are they able to unpack that and do something with it? We have to remove our personal bias and make sure we meet the patient where they are. We assume everybody understands what we understand. They know what we know. They're starting from where we're starting from. And just because of the barriers we've just discussed, we don't all start from the same point. So we really have to check that when we're making sure that we provide information to patients in a way that they can find, understand, and use it. And not just in your personal practice, but at an organizational level. Okay, so I can be accountable for what information I share with patients, how I share it with patients. But maybe this is an opportunity for you to advocate within your health system. What is our process for patient education? How do we equip patients? Do we have group classes? Do we have standardized educational material available? Is that educational material meet health literacy standards and expectations? So we have to think of our own personal accountability for making sure our education is health literate, but when we also need to advocate for that on a larger system level for our patients. Next slide, please. And health literacy is fundamental to quality care. So in the literature, it is clearly evidenced that poor health literacy leads to poor outcomes. So increased utilization, decreased participation in preventative care, reduced medication and care plan adherence, increased healthcare costs, and death. And these are all the things that we're fighting against every day, right? We want you to have appropriate utilization. We want you to get all the preventative care that you need. We want to make sure you're adherent to your medicines. This is like the bread and butter of what so many of us on this call do. But poor health literacy just already, it tilts the scales in the wrong direction for a patient when they present with that and leads to poor outcomes. So I like the KISS methodology of keep it simple, stupid, right? Watch your language. Make sure that you are speaking in plain language. So when we think of literacy and health literacy are not identical in their definition, but the average American reads at an 8th grade level. The average Medicare patient reads at a 5th grade level. And so you really universally need to make sure all your educational material is at a 5th grade level so that it is accessible to all and that it is plain language. So let's look at the next slide at some examples of what plain language are. So things like monitor your blood sugar to check your blood sugar, modify your diet to change what you eat, manage your weight to watch your weight. And some of those words might seem insignificant, but we really have to be mindful. I know that as a company, when we have new hires, we have so many different abbreviations for everything. And you can sit in a meeting and just be lost as to what's being talked about because did you get the MCV to the AWV to the MCP? And people are like, what are you talking about? I recently sat in a financial planning meeting and it was fascinating, but that's not my language. And all the abbreviations and the plans they spoke of were a stretch for me to wrap my brain around. And so I just really want to make sure that we pause and we're very thoughtful and mindful about the words we choose. So even the CDC gave an example of teach your child to manage diabetes at school by encouraging physical activity and healthy eating, as well as medication and testing routines. Sounds very professional, but you want that mama to know what to do to help their baby. So you want to encourage your child to be active, to eat foods that keep their diabetes under control when they're at school. You want to teach your child about the right way to check their blood sugar and take their medicines. And so it's just a simple evaluation of the words you use to make it understandable and relatable to patients. So we've already talked about the barriers of more older patients are more likely to have health literacy issues. But in addition to health literacy issues, there are other barriers specific to the older adult population. Some of them are cognitive changes then that influence their learning needs. So I want to spend some time talking about the impact of aging on learning. So we have declining cognitive capacity, oftentimes short-term memory loss. We have slower information processing, decreased capacity to manage multiple messages, and the decreased ability to inference and draw conclusions. Next slide. Other age-related factors is sometimes within the older adult population, there is social isolation and depression, a low motivation to learn. What's the point now at this age in my life to change anything? It's too late. There are psychosocial issues, high stress environments. Sometimes your sick, frail patients are the caregivers of other members within their family, or they have very low support. Functional decline in their hearing and their eyesight, and then a propensity to be fatigued, more likely to be fatigued. They tire easily. So these are all things that we need to consider when educating our older adult population. So specifically, when I went looking, I found these strategies for the elderly. I actually think these are foundational strategies for any patient in any population. So we recently had a friend who owns a business, and she did a radio announcement advertising her business. And at the end, we were like, that sounded so professional. And that just was really well done. What a great commercial. You know what the radio people told her? Talk like you're speaking to children. Have the cadence in your voice, slow your pace, make it animated. And it came across so relatable and just so well done. And it was act like you're speaking to a kid. Some of these things are the same types of principles. So let's provide written materials so that if they have short-term memory issues, or if you're just inundating them with everything's different. You're telling me I've got a new problem. I've got to do all these things to fix that problem. I don't know where to start. Let's give them something as a point of reference to look back on. And because of that changing eyesight, it needs to be 12-point font or larger. We need to limit distractions. We need to repeat main points multiple times throughout your time with them. And we need to stick to only 3 to 5 main points in one session. You need to speak slowly. You need to be concise. You need to avoid vague words, as specific as you can be. So if you say, make sure you have adequate intake. Well, what is adequate? How do we define that? You need to make sure you use the bathroom frequently. Well, what is frequently? That needs to be defined. Follow this until it's better, or several times a day. You've all had the poor patient who several times a day meant every hour versus 3 times a day. So we really got to make sure that we're avoiding vague words and we're being specific. Lowering the pitch of your voice. So I've always thought when I listen back, I sound like a 12-year-old girl. That squeaky voice on the phone. And I used to, in patient rooms, I'd speak so loud and I'd have patients say, honey, I can hear you. You don't have to speak so loud. But sometimes we think we need to speak louder, but instead of louder, sometimes it is slower, and we just change the pitch of our voice to be a pitch that patients can hear. And then we need to include the family and the support system. So depending on what you're educating, if the patient's not the grocery shopper, you got to include the grocery shopper in that education, right? If the patient's not the one dispensing the medicines and understanding the medicines, then you've got to meet with that person to change the patient behaviors and the outcomes. And so these are some foundational strategies that we can follow. So let's move next into some of our teaching strategies. So we've talked through some of the foundational elements of patient education. We've talked through some of the barriers to learning, specifically health literacy and that of an aging adult. Let's talk now on some of the strategies to make sure that we're meeting patient needs as we educate. So the 3 A's of health information: accurate information, actionable information, and accessible information. Accurate, let's start there. How many of your patients know what they know about their diabetes because they talk to their neighbor and their neighbor does X, Y, and Z? Or how many of them Googled something and they don't know where they found it other than they Googled and it said so? So we really have to make sure we make sure patients have access to accurate information, that their source is not their neighbor who is misinformed but well-intentioned, and that it's not just the first thing they found on Google, but it's a well-trusted site which has sound medical advice, right? Again, we're going to always come back to actionable because the point of patient education is to shape patient behaviors. So then the health information needs to be actionable. What do I need to know? And now what do I need to do with it? And then accessible, that goes back to not just do I have handouts for you or can I meet with you to talk through your questions, but it's considering those things like the barriers that are competing for your attention. It's can they hear you when you're talking? Can they read the material you're giving them? Do they have the health literacy to comprehend and understand and act on the information that you're giving? And so many times then that's taking it one bite at a time. How do you eat the elephant? One bite at a time. If you have a patient who's had a major life altering event and everything in their life is different now because of that event, you have to make sure that you meet them where they are and you take it one step at a time. They're not going to change their diet, their medication regimen. So this is really important to me. My husband had a heart attack this year, and we all thought he was too young and too healthy to have a heart attack. All of a sudden, overnight, everything changed, right? He went from no medicines to 8 new medicines. He went from no restrictions on his diet to severe restrictions on his diet because he was in heart failure. We went from being active runners every day to we had to get permission to walk to the mailbox until he built up his recovery and his tolerance. And so when I think now about all the things that are going through a patient's mind, right? He did not want to have another heart attack. He did not want to go back to the hospital. He was willing to listen to anything you wanted to say that would keep him out of the hospital and keep him from having another heart attack. But he was also drowning in information because everything changed at once. So we had to do bite size. I'm going to do your medicines. You do your diet. We had to take it one step at a time, and we had to participate in things like cardiac rehab, where he went every week and he learned something new every week. So he built upon that. We had to do the one bite at a time approach. And that's how it was accessible and actionable to him, because that's what he could process at the time. So I'm really passionate about this because I've seen it firsthand now, and it really connected. Like, oh yeah. Patients recall 10% of what they see, 30 to 40% of what they see and hear, and 90% of what they see, hear, and do. So I know personally, if you send me an email with a big attachment to read, it's a stretch for when I'm going to read it. If you really want me to know something and you want my answer on something, schedule a 5-minute meeting and tell me what's in that attachment and ask me the questions you need to ask. And I will pull up that document and I will reference it in the conversation. And if you're talking to me, I want something to hold on, read, highlight, take notes. So I personally can see in my own life that it's not, I just don't want to see it. I also don't just want to hear it. I want to be able to see it, hold it, hear it. But then I learn best from doing. And so when you think about where you're meeting these patients for patient education, if you're just mailing them a flyer, not a lot of traction. Not a lot of impact. If you're mailing them a flyer and then you're talking to them about it, you're talking them through it, they're holding it in their hands, you're a whole lot closer to the outcomes you desire. But really, if you want to move the needle, you want to make sure that they have the opportunity to see, hear, and do. And then that's how patients learn best. Next slide, please. So another strategy would be to chunk and check. So it breaks these large amounts of information into smaller sections, like we've done in our PowerPoint today. We first started off on the power of education, then we talked about health literacy, then we talked about learning needs of older adults. Now we're talking about patient education strategies. We're chunking it into smaller bits of the overall, the entire presentation's about education, but it's broken down into discernible parts. And it enables you then to validate the understanding of each item taught. It allows patients to clarify and ask questions in real time rather than waiting and forgetting. And when you chunk and check, you want to prioritize what you want to teach and begin with the most important information first. If they only hear one thing, let's start there and let's repeat it frequently. But chunking and checking then allows you to come back. And so if you don't get the intended results from what you did, you know where the process broke down. Was it in this section or this section? Like where did the communication break? What do I need to revisit? So then that lends itself nicely into the next slide. And that's called teach back. And teach back is an opportunity to help gauge comprehension, and where you really think that you're evaluating whether the patient understood you or not, but really you're understanding that how effective you were at communicating your point. So how often does this happen in real life? I think I've communicated one thing. The results I get are not at all what I thought I communicated. So there is a disconnect. I think we could all use this in every aspect of our life. So really having the teach back, tell me what you heard, tell me what you understood, really helps make sure that what you intended to communicate was indeed received and understood. And so then utilizing teach back, you chunk and teach the information. Then you ask patients to teach it back in their own words. If they get it right, we move to the next chunk of information in those 3 to 5 main points we're trying to communicate to a patient. If they don't have it, we use different words. We have a different approach. And then we come back to tell me in your own words what you understand. Next slide, please. In utilizing teach back, there's a couple of things that you don't do. And some of this is foundational communication. I learned very quickly with teenagers that I do not ask yes and no questions, because all I will get is yes or no and nothing else. So I have to ask open-ended questions to facilitate dialogue and to really have more context to the conversation. Same with patients. Yes, no, do you understand and do you have questions? These are all things that patients can hide behind, because yes, I understand. No, I don't have any questions. And you leave not knowing whether they really understand or not. You're looking at their facial clues, their body language. Do you think they understood it? Do you think they're going to do something with it? So we need to change and ask open-ended questions. We need to say, I want to make sure I explain things well. Tell me in your own words so I make sure I did. Can you tell me in your own words what you're going to do differently from today? And instead of saying, do you have questions? It's what can I explain more clearly? And is there something you want to review more? So often with patients, specifically with health literacy issues, literacy or comprehension issues, there's a lot of shame, and patients don't want to disclose that they don't understand or they don't follow. So instead of saying, they might not want you to know they have questions, because that means they didn't understand it and they don't want you to know that. But if you say, you want to talk more about one of these particular things? Can I explain something more clearly? That's a level playing field for that patient to say, yes, let's talk about this some more. right? If you say, do you understand? Patient's always going to say, yes, I understand. And they might not have a clue. So these open-ended questions, tell me in your own words, tell me what you're going to do differently based off what we talked about today, and what can I explain more clearly? Next slide, please. So the benefits of written material as a teaching strategy are a couple of different things. It helps to reinforce learning and prompt recall of the information. So we already talked about in elderly patients where there is poorer retention of information, memory issues, having something to go back to can be really, really helpful. In the instance where a patient's having to learn lots of new things and everything starts to jumble together, having something to come back to, again, prompts that information recall. I think the one thing, though, that makes it personal to patients is if you are doing handouts, that you highlight the main point of that paper. So they're not just looking at a page full of words, but you're saying, this is really important. Read this sentence, read this 2 sentence, make a personal note. Paul, I hope this is helpful to you. Post this on your refrigerator. Helps to engage the patient. So it takes it just from being a piece of paper. And then following up on that written content in your phone calls to make sure that they're not just seeing it, but they're seeing and hearing it. And then you give them action items to do following that. The other benefit of written material is it helps to standardize education. So I have a large team of excellent nurses, and I would trust my grandma to any of the nurses on my team. But I also know that if she was to be educated by 5 of them, they'd take a different approach. Each of them would prioritize something different for that. And so helping to standardize it, one thing we had to do as a department is, okay, for diabetic patients, what are the critical things everybody wants to communicate to a patient? Let's make a packet of information we're all going to teach from. Because otherwise, you might have one nurse who only focuses on your diet, and one who only focuses on your medicine, and one who only focuses on your exercise. And everybody has a different priority of what they want to communicate and educate. So it helps to standardize that all patients get the same information. The other thing, when education is standardized, then it gets repeated. So if the doctor's office is handing out the same information that you are teaching from, we're all communicating the same message. I'm not looking at 4 different papers all telling me the same thing. The doctor's office gave me this paper, you, the nurse, are calling to follow up on that paper. And that really helps to streamline the patient and give them something tangible to understand and do. So as far as the benefits of written material, I think it really goes a long ways, but you also need to do the other modalities of how you're going to get that written material to patients and how you're going to follow up to make sure that they understood it, that you're addressing additional concerns, that you're following up and equipping them and giving them the opportunity to see, hear, and do. Next slide, please. So I want to thank you for your time. I want to encourage you that you are difference makers, that you have a unique opportunity to shape patient behavior, to influence patient outcomes, to equip patients for success. You make all the difference in the world. And I really am grateful to know that we have this opportunity before us and this ability to impact people. I'd really like to, we have about 5 or 10 minutes before we transition to the next slide and the next presentation. I want to practice what I preach, right? I was preparing the presentation and I was like, when do I check their validation and their understanding of what I've communicated? But most of the presentation, I preached drive to action, drive to action. So we've all presented we've all participated in education before where it says, what did you learn today that you didn't know? I don't want to know what you learned you didn't know. I want to know what you're going to do differently because of what you learned today. So is there 2 or 3 people who want to say, because of what I learned today, I'm going to start asking open-ended questions. I'm going to start highlighting my patient information that I mail to patients. Does anybody want to volunteer something they're going to do differently based off of what they learned today? Let's see. Teach at a 5th grade level. Very good. Open-ended questions. Anything else? You're a quiet bunch. So instead of asking if they have questions, what can I go over in more detail? What can I clarify? Slow down. Speak slower. Tell me in your own words. Repeat what I've told you. Very good. So I'll leave that with thank you, and go change the world, one patient at a time.
Thank you, Shannon. That was outstanding. Our next presenter, we're proud to introduce Rebecca Grandy, the Director of Pharmacy at Chess. She may be a new face to some of you. She's been with us for a few months, and she has already made a huge impact at Chess and the way that we are handling all of our pharmacy matters. A little bit about her background is she grew up in a small community in Western North Carolina, and a love for college basketball and Vince Carter led her to the University of North Carolina at Chapel Hill. I totally a woman after my own heart. Where she earned both her undergraduate and doctorate of pharmacy degrees. The Tar Heels didn't look so good last night, but I'll leave that for another day. So after graduation, she moved to Asheville to complete an ASHP accredited residency with Mission Hospital and the Mountain Area Health Education Center, also known as MAHEC. So after this residency, she worked as an outpatient clinical pharmacist at Mission Hospital. Then in 2014, she took on a new role as a pharmacy faculty member with the Family Medicine Department at MAHEC and the UNC Eshelman School of Pharmacy. This position allowed her to integrate into the healthcare team as a clinical pharmacist practitioner and develop a love for family medicine. Her clinical interests have since focused on rural health, improving medication access, and serving underserved populations. Rebecca is here to share the most recent recommendations and strategies for diabetes. That's a tongue twister. Diabetes management from a pharmacy perspective. Welcome to the Move to Value Nursing series, Rebecca.
Thank you, Thomas. Yeah, and I will say over my career, really ever since I graduated from pharmacy school, I've had the opportunity to work with nurses, both in a health education center and then later in family medicine and internal medicine. And I've just always really appreciated the collaborative care and how we've been able to work, synergistically with all of our strengths that we bring to the table. And so just really happy to be here today with you all to talk about pharmacy and specifically diabetes management. We could spend all day talking about diabetes. And so Shannon let me pick her brain about, okay, what is it that, I should talk about with the nurses? And we narrowed it down to 4 things. So the first thing we're going to talk about is sort of a reminder of when you think about someone with diabetes, there are lots of things beyond the A1C that are even more important than the A1C. And I think for me, especially transitioning to the value-based world where I'm thinking about, are they adherent to their medicine? What is their A1C? Are they on a statin? Sometimes it's easy to get lost in that big picture of really taking care of the person. So I want to spend some time on that. I'm going to spend some time just talking about the 2023 diabetes guidelines. The new ones for 2024 should be out any day now. And so I don't anticipate any major changes. So I want to review some of those things with you. And then there are 2 classes of medicines, SGLT2s and GLP-1s and GIPs that I want to spend a lot of time, sort of the bulk of the conversation around. And then lastly, after someone gets a prescription for these medicines, what happens next? So thinking about how do they get the medicine? How do they afford it? How do they remember to take it? And should they be checking their blood sugar? Because that's a really interesting, sort of controversial topic. So we'll jump right in. All right, next slide. Okay, and so we have this thing called Slido. This is my first time using it. But the way this works is if you have a cell phone with you, if you will take a picture of that QR code, it'll bring this question up for you and you can vote on what answer you think is right. And then at the end, we'll revisit the questions to see if what I did was clear in explaining the different concepts. So when you do this QR code, please answer this question. Which of the following has the greatest impact on morbidity and mortality in patients with diabetes? So is it blood pressure control, smoking cessation, lipid reduction or cholesterol management, or lowering their blood glucose? Okay, you see we have about 27 votes. We want 29. Do we get to see the results, Megan? Okay, so I feel like I have something I could possibly teach you all today. So blood glucose control was 61%, then lipids, then blood pressure, then smoking cessation. Okay, this is great. Okay, next slide. Okay, so back when this article came out called Lending a Hand to Patients with Diabetes, a simple way to communicate treatment goals, one of the medical residents at the family practice where I worked at did this as part of his journal club. And ever since he did it, it's just always been an easy way for me to remember kind of all the different things I should be thinking through when I'm caring for someone with diabetes. So this particular article came out in 2014. A few things are outdated, a few things are a little controversial, and so I'll point those out. But when you look at this, you want to start with your thumb. So your thumb is actually where you can make the most impact with people who have diabetes. And so believe it or not, it's actually smoking cessation. So smoking cessation has some of the biggest effects on mortality and morbidity when it comes to someone with diabetes. It's not their A1C, it's actually whether or not they smoke. And so when you look at this slide and you look at the thumb and it says smoking cessation, decreased mortality, there's this thing that says NNT equals 11 over 10 years. So what does that mean? NNT stands for number needed to treat. So it's basically how many patients do we need to have an intervention on, whether that's the medicine or the program. I have a friend, my cat likes to help me present. It's basically how many patients do we need to treat to get one person to benefit. And so for smoking cessation, we need to treat 11 patients for one person to benefit from mortality. So we're preventing them from dying over a 10-year period. So when we go through the different fingers, you'll see the number needed to treat for different interventions. And I think it's always good to know, okay, is that a good number? Is that a bad number? What's it relative to? So in the medical world, when you're thinking about an intervention, whether it's a medicine or a procedure that has sort of standard risk, a number needed to treat less than 10 is actually really good. The other thing that I think helps put it in perspective, does anyone want to guess what the number needed to treat for one person to benefit for aspirin is? So when you give some aspirin to someone who's never had a heart attack or stroke, which historically has been done a lot. Anyone want to guess what that number needed to treat is? You can put it in the chat. Anyone brave enough? 25. Thank you, Casey. Anybody else got a guess? 100, Tish, 110, 120, 333. Now, let me repeat what I said. For someone who's never had a heart attack or stroke, you have to treat 333 people with aspirin to get one person to benefit. So when you look at some of these numbers needed to treat, they look pretty good. I could talk all day about primary prevention with aspirin, but anyway, just to give you some perspective about these numbers. So smoking cessation makes a huge difference for our patients. The next one is blood pressure control. So when you look there, mortality, right? So whether someone lives or dies, 15 people over a 10-year period. To decrease any kind of complication, 6 over a 10-year period. The middle finger there, which I'll go ahead and highlight, if you'll click the next slide, please. The middle finger there, this was before some of our newer medicines came out, but metformin is still a really good medicine. Metformin has benefits to our body beyond blood glucose lowering. And so some of those other benefits that metformin has can decrease mortality and decrease complications. Now, as you see, when we start talking about some of the newer medicines, if they were to redo this article now, I think in addition to metformin, they would also put SGLT2s, which later I'll tell you what some of those medicines are, and GLP-1s. So when I'm thinking about someone with diabetes, I also think through, okay, what medicine for this patient treats diabetes, but also has another benefit beyond lowering their blood sugar? And then as you can see, the ring finger there is lipid reduction. So, this is why we harp on statins all the time. For most of our patients, they're going to be the best choice because you need about 10 patients to be treated over a 10-year period to get a decrease in cardiac events. It extends life, but not just life, but quality of life, right? And then the pinky, this one's a little controversial, but interestingly enough, glycemic control or controlling someone's blood glucose has debatably no effect on mortality, so whether someone lives or dies. And then this article also says no clinically relevant complications. I do not agree with that part. Neither did several folks who put in commentary to this. And so this was from the American Family Physician article, because when you think about glycemic control, and I think about controlling someone's blood sugars, in my mind, I'm helping protect their eyes from retinopathy. I'm helping protect their kidneys. And those things are important. May not be life and death, but definitely affects quality of life. So I show this just to say we talk a lot about blood sugar, and it is important, and it's a lot of what the quality measures are about. But I don't want us to lose perspective on all the other things that we need to do to take care of people with diabetes. Next slide. And so, those were just about the medicines. And so when I think about sort of that, patient-centered approach, and like Shannon said, having the patient as the MVP, having nursing on the team, having social work on the team, when you back up even further and think about that patient, I mean, it's way more than just about the clinical care, right? So as y'all know, the clinical care that we provide only impacts about 20% of that person's health outcomes. It's all these other things really when we're holistically caring for someone. So as you can see here, this actually comes from the 2023 diabetes care, so the ADA standards, the American Diabetes Association, and they really want to emphasize that whole person care. So thinking about the individual patient characteristics, and how those impact our choice of treatment, whether that's medication or lifestyle, using shared decision making, having SMART goals, and then after you implement that plan, really providing ongoing support, monitoring, reviewing the plan. So this section, again, I just really wanted to make sure as we dive into the weeds, some of the blood glucose lowering medicines and A1C recommendations, that we don't forget about that whole person picture. Next slide. Okay, so we're going to dive into the 2023 treatment guideline updates. And like I said, these new guidelines should actually come out in the next couple of weeks, but I don't expect major changes. But I do have a question for you. So according to the most recent guidelines, the 2023 guidelines, metformin is still first-line therapy for all patients with diabetes. This is kind of fun to watch the votes come in, and it changed the true and false percentages. Okay, it looks like we're going to land on about 75% of people saying true and 24% of people saying false. So let's kind of dive into those, and I'll tell you whether or not that's true or false at the end. Um, I actually really like the American Diabetes Association guidelines. So when I think about all the chronic conditions, hypertension, lipids, diabetes, most of them, we have to wait years for new guidelines to come out. The ADA is like clockwork, comes out the end of December for the following year. And the other thing that they've started doing, which I really appreciate, is if there's anything significant that happens within the course of the year, they'll actually update them in real time on their website. And so when you read through this slide, it says it's a living document, and that's what that means, is they update it in real time. And so as we go through the next few slides, some of the slides are terrible slides. The font is so small, you're not going to be able to read it. And my intent was not that you can read it, but just to let you know what's available in those guidelines. So if like you're on a team providing care for folks with diabetes, just to know what resources you have available, because there's some really cool and informative and easy to use charts and pictures in these guidelines. And these are available for anybody on the website. You can go get them for free. They're in a PDF. Okay, so kind of thinking about first line therapy. So these are actually guidelines, snippets from the guidelines that I want to focus on. And as we talk through the medicine, sort of in the third portion of the presentation, we'll go into some more specifics. So a person-centered approach should guide the choice of pharmacological agents. So in the past, what the guidelines have said is we use diet and exercise and metformin. And then after we use those things, then it's kind of a free-for-all as to what you use. You know, there were like 10 different choices after that. Now they're much more directed when you think about someone's comorbidities. So they really want you to think about cardiovascular effects. So some of our newer medicines have positive effects on your cardiovascular system and your kidneys. Some of them, beyond their blood glucose lowering, actually affect the kidneys. And then there's been a big focus on helping someone either maintain their weight or lose weight. Some of the medicines that we have cause weight gain because of the way they work. Some of them can cause weight loss. And so those things that I've highlighted there have really been an emphasis in these guidelines over the past few years. And so, back to the previous slide, please. And so you can see there, I would just to kind of orient, when you look at that 9.8 and you look at the end there, it has an E. So what that E means is that's just expert opinion. This is just the opinions of the people who wrote the guidelines, right? Like this is the way we think you should do it. But when you look at 9.9, so this next recommendation, so for those people who have type 2 diabetes that have established cardiovascular disease or are at high risk, have established kidney disease or heart failure, then we need to consider a sodium glucose cotransport 2 inhibitor. So from here on out, we're going to call that an SGLT2 because it's a lot easier to say, or a glucagon-like peptide 1 or GLP-1 receptor agonist. And so we're going to talk about all the names, the generic names, brand names of what those are later. But I'll point this out because in the past, where, like I said, it's always been lifestyle metformin, and then we kind of figure it out from there. That's not what we do anymore. From here on out, what we do is we think through, does this person have heart disease or are they high risk? Do they already have kidney disease? Do they have heart failure? And if the answer is yes to one of those three, you actually are going to go kind of a different route. So next slide. Okay, so this is one of those slides that you're not going to be able to read, but I am going to show you each portion of it. So this is sort of the decision tree around which medicines that you're going to recommend for your patients. And so when you look at these, they're actually divided up between those disease states that I talked about on the left side, and then on the right side, it's all around weight management. So again, a big focus on weight management because of some of the newer toolkits, you know, some of the newer drugs in our toolkit that we have. Next slide. Okay, so this is a little small, but we're going to walk through it. But this is where you say, okay, does my patient have heart disease? Do they have heart failure or do they have kidney disease? Some of the newer medicines that we have can actually protect against those things. So if you see in the blue, this is ASCVD. So we already know they have heart disease or they're at high risk. And so for high risk, things like you would expect, right? Obesity, hypertension, smoking, do they have cholesterol or do they have albuminuria? So do they already have protein in their kidneys? Because that actually is an independent indicator of high risk of cardiovascular disease. So when you look there and you know they have those risk factors, you can either do a GLP-1. So things like GLP-1s are semaglutide, which is Ozempic, or let's see, what's another one? Tirzepatide is a combination one, but that's Mounjaro. So we'll talk specifics about those later. But they're injectables. They have a lot of great benefits, but they're expensive. So we're going to talk some about that. Or you can do an SGLT2. So that's things like the brand names when you think about them would be like Farxiga, Invokana, Jardiance, those medicines. They're pills. They're also expensive, but they're really good, and most of them have benefit in cardiovascular disease. So in addition to lowering your blood sugar, because we know lowering your blood sugar can help with complications like retinopathy, kidney disease, but they also protect your heart and can prevent heart attacks and strokes. And then when you move over to the red, that's for heart failure. And so for people, and this is true for reduced ejection fraction. So for those people who have an ejection fraction of less than 40, there's benefit, but there's also benefit in patients who have heart failure with preserved ejection fraction, so greater than 40. And so for some of our medicines, even like ACE inhibitors and things, that's not necessarily true, but it's true for these SGLT2s. So that again, the brand names, that's like your Farxiga, Invokana, Jardiance, those medicines, great for heart failure because of the way they work, which we'll talk a little bit about. And then even some of these medicines can protect your kidneys, which I think is pretty cool, right? So if you have someone that has a GFR less than 60, or they have albuminuria, so that's that microalbumin, that we're checking for one of our diabetes measures, then some of the SGLT2s and some of the GLP-1s can benefit. And so I show you all this just to say, if your patients have any of those conditions, metformin's not necessarily first line. Is it wrong? No, it's a good medicine. I really like metformin, has a long history. It's cheap. It works well. It may have some mortality benefit, but these other medicines we know have even greater benefit in those patient populations. Okay, next slide. Okay, and so this is the other half of that decision tree around medicines. And I show you this just because, again, now there's more focus on weight management, either maintaining weight and not having someone gain, or lowering their weight, which a lot of these medicines do. And so we're going to kind of jump into that. And it's been really interesting because of the weight loss potential of some of these medicines. As you all probably know, there's been drug shortages, and it can kind of throw off our diabetes measurements. And so we'll talk some of the nuances about that when we get to the actual diabetes meds. Next slide. Okay, can't read this, and we're going to walk through it though, but we're only going to cover two classes of medicines. So we're going to talk about your GLP-1 receptor agonist, and we're going to talk about your SGLT2s because those are sort of the ones that are highlighted in the new guidelines. But for any medicine any class of medicine you can think of for diabetes, this is a beautiful chart that's in the guidelines that talks about how effective is it in relationship to other medicines. Does it cause low blood sugars? Does it cause weight gain? What are the heart, kidney benefits? Is it only oral, or do I have to inject it? And then there's really good clinical considerations, and I think they're really practical ones. So we'll walk through some of these, and I can just share personal experiences that I've had in the clinic with different medicines. Next slide. Cost, it's always an interesting thing. I used to get asked all the time, like, well, how much is this med going to cost this patient? And I'm like, you know what? I really have no idea. It depends on their insurance. And so medications, it could be a really, really expensive medicine, but depending on that person's insurance design, which usually we can figure out for the patient, it may be really, very affordable. And we'll talk about some of those pricing considerations with some of these newer medicines, because I think it's important that when we're prescribing them or have patients on them, we think about the consequences of the cost. Next slide. Okay, so we're going to jump into those SGLT2 inhibitors and GLP-1 and GIP agonists and review some of that. So we have another knowledge check. So tirzepatide, and in case you know brand names better, that one, the name of it's Mounjaro for diabetes. The weight loss version or for obesity just came out last week, I think, and it's called Zepbound. So how does that one work? Does it slow gastric emptying? Does it increase your insulin sensitivity? Does it increase satiety? Or does it do all of the above? And satiety, as y'all know, is just that feeling of fullness, right? Okay, thank you for voting. So it looks like about 70. We're going to land on about, oh, actually, we're up to 80% now. Say all of the above. Okay, so before we jump into those, I'm actually going to talk about SGLT2 inhibitors or sodium glucose transport inhibitors. And like Shannon said, like I like information, but I like to understand the why behind the information. So I'm going to talk a little bit about how these medicines work. And the only reason I'm doing it is because, at least for me, I learn best with stories. It just helps me understand what the side effects are and sort of some of the counseling points that we have. So SGLT2 inhibitors, again, the brand names of those are Farxiga, Invokana, Jardiance. They're the ones that have evidence for protecting your heart. They're the ones that have evidence for your kidneys and for heart failure. So they kind of hit all three. And so the way they work is they alter how our kidneys reabsorb glucose. So as y'all know, let's say a patient's blood sugar is 500. One of the ways that we get rid of that excess blood glucose is by peeing it out, right? Glucosuria. So you pee it out because you have this extra glucose, but usually the body doesn't do that. I believe the number's around 250, right? Your blood sugar has to be pretty high for your body to do that, but it is a mechanism for us to get out that extra sugar. Well, with these medicines, what they do is they work inside your kidney to actually, in the nephrons, to actually lower that threshold. So instead of now our blood sugar has to be 250 before we start peeing out the sugar, it only has to be around 150. And so there's some really nice things that come from that because, as you all know, where sugar goes, the water goes. And so they work as a diuretic. So if you're peeing out more sugar, you're going to pee out more water. So that diuresis part. And so when we think about some counseling points, we'll need to think about that, right? Because they're causing our body to get rid of water. The other thing is because they're so dependent on our kidneys to actually be effective, when we look at renal dosing, and like, oh, well, if it's, someone's EGFR is less than 30, then we need to decrease the dose or we need to not use these medicines. So I say that to say, it's not that these medicines hurt your kidneys. That's not the case. It's just that if your kidneys don't work well at baseline, the medicines don't work well. So if in a normal, healthy individual, you would expect these medicines to lower your A1C maybe 1.5 percentage points. In someone who has kidney disease, it may be closer to a 0.5%. So again, it's because of the way they work. But as you can see here, when you think about, well, why would they be effective for heart failure? Why would they be effective for these other things? They decrease preload, they decrease afterload. You can get some decrease in blood pressure. You see here arterial stiffness, volume of blood, body weight. So it has a down arrow, which is true. They can cause a little bit of weight loss, but not really our heavy hitters if weight loss is a priority. Decrease glucose, decrease insulin resistance. So just a lot of good effects that they can have because of the way they work in the kidneys. Next slide. Okay, so this is where I've taken that chart from the ADA guidelines and kind of put it in my own words and put some things that I thought were important in here. These meds are really effective, kind of in that intermediate to high range. And so some of it just depends on how well your kidneys are functioning because of the way they work. And so again, usually you can expect an A1C lowering of about 1.5 percentage points. Low blood sugar. No, don't cause low blood sugar. So as the medicines we talk about today, none of them do because of the way they work. And so we'll go a little bit more into that with the GLP-1s. Weight change, it's a loss, it's moderate, usually like no more than 5% of someone's body weight, but that's pretty good, right? It's better than weight gain. So there are some medicines that cause weight gain. And then this next column, these next two columns that I've put in red are around the heart benefits. Yeah, and Carla said, I've seen some heart failure patients without diabetes on Jardiance. Yes, so these medicines are actually approved for heart failure with or without diabetes. So when you look at the heart failure guidelines, these are actually in there as well. And so one of my colleagues used to say, we don't ever want to say hit two birds with one stone, because that's really mean. And why are we throwing stones at birds? So she would say, we can feed two birds with one seed. And so these medicines are kind of like that, right? And so if you have heart failure or diabetes or both, you can use them. Yep, not, and some unknown user said not required to have diabetes for SGLT2s. Correct. You can use these in people who just have heart failure. The red parts, columns that you see here are really related to the heart effects. So I don't know if y'all remember, the brand name of the drug was Avandia. The generic name was rosiglitazone. It was a medicine. It was been around for a while, but there was a lot of debate around whether it caused heart failure or not. And ever since that medicine came out, for any diabetes medicines, they make you test its effect on the heart. Does it increase risk for heart failure? Does it increase risk for heart attacks? Or conversely, does it have a protective effect? So this thing that says MACE here, that stands for major adverse cardiac events. So heart attacks, is the big one in there. So is there a benefit? And so for two of these meds, there actually is. So for canagliflozin and empagliflozin, and I put their brand names below them because I'm making some assumptions that a lot of folks are familiar with the brands, since all these are brand name only right now. They do have benefit. And then for heart failure benefit, almost all of the SGLT2s have benefit. And then if you go to the green section, I put a lot of this is for diabetic kidney disease. So you actually get benefit from there too. And so you can see from a brand name perspective, Jardiance and Invokana kind of hit all three buckets. I will say, Invokana a few years back got some bad press because it was linked with increased risk of lower limb amputation, which we'll talk about a little bit in clinical considerations. And so I've seen a lot more Jardiance and Farxiga since then, just because of that. As far as dosing considerations, there are some renal dosing considerations, but again, it's not because they hurt your kidneys, it's just because they're less effective at lower eGFRs. These are oral, so some people, feel very hesitant about injectables. I think for most people, they link that with insulin. And unfortunately, we've had a culture in medicine that's penalized people with insulin and put insulin as a last resort. So a lot of people have this connection with, oh, I'm on insulin, I've got the bad diabetes, or oh, when my mom went on insulin, she lost her leg. So we have a lot of stigma to get around with insulin there. And so for that reason, a lot of people prefer orals. So these are oral. They are expensive. So as you can see here, if you had to pay cash for those, about $500 for a month's supply. And then just some things we should think about. Diabetic ketoacidosis has been seen with these medicines, and I think it's important to know that it's even for patients that are euglycemic. So when you think about diabetic ketoacidosis, in my mind, I'm usually like, oh, that's for people who have blood sugars of like 500. Well, not with these medicines because of the way they work. It's actually been seen in folks who have blood sugars in the high 100s. But when you look at the actual numbers compared to placebo, you can see here they're pretty similar and it's pretty rare, but it is just something to keep on your radar. If you have someone who's going to be having surgery, they're having a lot of nausea and vomiting, they're going to be fasting a long time, you may want to hold these medicines for 3 to 4 days, and that's because of the way they work. Because they make you pee out more sugar. Because you pee out more sugar, you get rid of more water, so you're having that diuresis. And it's really easy to have some acute kidney failure or acute kidney injury if you're getting rid of all that fluid, but you're not actually replacing it orally. Increased yeast infections. So these are usually mild and treatable. So when I'm counseling people, I usually say, if it's a female, I say, you would do all the things you would do anyway to prevent a yeast infection, right? You're going to wear cotton underwear. You're going to make sure you have good hygiene. For men, it's mostly men that are not circumcised that are going to be a little bit at increased risk. I will say I have had patients before who have stopped these because of yeast infections, recurrent yeast infections, but it hasn't been a lot. The other thing that comes up in rare reports is necrotizing fasciitis of the perineum or Fournier's gangrene. In my career, have only seen that once, and it was not associated with this medicine, but the person did have diabetes, and we did not put him on this medicine because of that. And so the big thing with these are, counseling patients to stay hydrated. If they have heart failure, they're probably using other diuretics like furosemide, torsemide, whatever it happens to be. So it's just really important they stay hydrated because of the way they work. Next slide. Okay. So now we're going to move and kind of shift gears into the GLP-1s and GIP agonists. And these are some of my favorite medicines. So I have a couple of, I think, really cool, maybe geeky stories to tell you about these medicines. So these are ones, when you think of brand names, it's going to be like the Ozempics, the Victozas, the Trulicities, all these injectables. So does anybody know well, let me back up. The very first one that was approved was in 2005. It was exenatide, which was Byetta, later branded as Bydureon, once weekly. Does anyone know where that medicine came from? Anyone want to guess where they found it? I'm watching the chat to see if anything pops up. It actually came from pig. That's actually a really good guess, Carla. Some insulins come from pigs, right? It actually comes from the venom dragon, sort of. It's called the Gila monster. It's actually a lizard that's found in the southwest US, and I think it's the only poisonous lizard in the US. But this compound was isolated from lizard venom. And then, so I think that happened in like the 1970s, and it took a while for them to actually figure out, oh, we could use this drug for diabetes. So in my mind, I'm like, that's really interesting. Why would you ever think that lizard venom could be used as like a diabetes med? But that's actually where these hormones were first isolated, was in a lizard. We've come a long way since then, right? So these hormones are ones that we naturally have in our body anyway. But when we have diabetes or when we have obesity, these GLP-1s and GIPs that we naturally have in our body are it's suppressed, and so we have lower levels. So I don't know if you've ever had a patient or yourself experience where you sit down to eat your supper, you have a good meal in front of you, you eat it, but you're still hungry. But in your head, you're like, this doesn't make sense because I know I've eaten enough. Well, that's because when people have diabetes, when people have obesity, there's a pathophysiological process that's happening where you don't have enough of these satiating hormones. The other thing that I think is really cool and really interesting about these is, if y'all have ever had experience with someone who's had like gastric bypass surgery, and then the day after they have their gastric bypass surgery, or even like maybe a week after it, they no longer need their diabetes medicines. And which is really, it's great, but it's like, well, they haven't really had significant weight loss yet. Why have we already cured their diabetes? After gastric bypass surgery, whether it's a Roux-en-Y or a gastric sleeve, these particular hormones called incretins increase naturally in the body back to sort of their normal physiologic levels. And so people think, there's some debate about this, right? But people think a lot of the benefits around even gastric surgeries are because of these hormones. So I just think these are really cool hormones because we found them from lizard venom. They're natural in our body. And some of the even gastric bypass surgeries, really some of the benefits coming from these hormones. So on the left-hand side here, you're going to see the GLP-1s. So that was like the exenatide, the Byetta, Bydureon. We'll talk about which medicines fall into that category. But as you can see here, they do lots of really cool things beyond lowering your blood sugar, decreasing your gastric emptying. They help your body increase insulin, but they don't cause low blood sugar because of the way they work. So these actually don't really kick in until you eat. They're glucose dependent. So these medicines are glucose dependent, so they're not activated until you're eating and have glucose in your body. Unlike sulfonylureas. So when you think about sulfonylureas, glimepiride, glipizide, those medicines cause your body to release insulin regardless of whether you're eating or not. They're not specific like that, and that's why you're at risk for lows. These medicines don't really cause lows on their own. They go to your brain and tell your brain, hey, you sat down, you ate supper, you've had enough to eat. You actually should be satisfied. So they increase that satiety feeling. They decrease your food intake. They decrease, of course, hyperglycemia, because that's what they do. And then in your liver, they actually increase insulin sensitivity. So that's a big thing with type 2 diabetes, right? Is that we just lose our sensitivity to that insulin. So these increase that. And then when you flip it and you look at the green side here, which is the glucose-dependent insulinotropic polypeptide receptor agonists, we're going to call those GIPs. We only have one medicine right now that targets that, and that's tirzepatide, which is Mounjaro or Zepbound, but it complements the GLP-1 in lots of ways. So when you look here, we're still hitting the central nervous system, still hitting the pancreas, but it's doing it in a way that's complementary. So, in our body, we have lots of compensatory mechanisms. Like you shut one out, the other one kicks in. Well, here you're actually hitting or feeding two birds with one seed. And then it also helps with a lot of the sensitivity to insulin in your skeletal muscle and in your fat, which are also really important. And Catherine said, I'd love to hear your thoughts on the compounded versions like semaglutide with B6 compounded instead of name brands. So yes, I can touch on that a little bit. Okay, so next slide. So thinking about these medicines, are they effective? Yes. And so the ADA actually categorizes these as high to very high. So depending on the medicine and the dose, you're looking at about a 2% reduction in A1C, which is really good. And doesn't cause low blood sugar because these medicines, again, are glucose dependent. So they only kick in and help your body use your insulin if you're eating and have glucose in your system. Weight loss. So you're going to get that, and it's going to be moderate to very high depending on the individual drug. So when you look at, and so we're going to move sort of our heart benefit now. And so when you look at this red section around major cardiovascular events or heart failure, you can see three here: dulaglutide, which is Trulicity, liraglutide, which is Victoza, and semaglutide, which is Ozempic. And here I put SQ because this really only applies to the injection version of semaglutide. So there is an oral version called Rybelsus that's out, but it doesn't seem to have exactly the same effects. Heart failure benefit, neutral. Not bad, not good, just neutral. But again, thinking back way back to the days of rosiglitazone, Avandia, that is something they want everyone, any new drug to be tested on, is that heart failure benefit or harm. And then these even protect your kidneys because of the ways that they work. And so kind of the same ones here, you'll see, I mentioned that exenatide, which is Byetta Bydureon, was the first one to come out. It's kind of fallen out of favor. The injection device historically was really hard to use. It caused a lot of adverse events because of the way it worked and got absorbed in the body. Like people would have these injection site reactions. And so it's really sort of fallen out of favor. And so you'll see these most commonly. And then as far as renal dosing, most of them are just fine. The biggest thing is if you know someone has renal impairment and you're going to start one of these medicines, they need to stay hydrated because it decreases your food intake. You decrease your food intake, usually your water intake is being decreased. And so if people get dehydrated and they're already having kidney issues at baseline, it's really easy to have some acute kidney injury or issues there. And I've seen that happen. And so you just need to be careful about that. Next slide. So why wouldn't everyone be on these, right? Well, a few reasons. One is that the ones that have the most benefit are going to be the sub-Q injections. Some people just have weird feelings about needles. Like I said, and there's lots of justified reasons for that, right? Like sometimes people associate injections with, I have the bad diabetes, I'm going to lose my limbs. I've had people, especially now, who have a history of injection drug use, and and needles are triggering for them, and they just don't want to do anything with a needle. So that's one reason. I will say, Trulicity, Mounjaro, and then the weight loss version of Mounjaro, which is Zeptide, actually come in these really cool injection devices where you never even have to see the needle. It's my favorite injection device if you ever want to know, if you want to Google it. Like Google Trulicity, Mounjaro, or Zepbound, and you can see how they work. It's my favorite. The other reason people don't use these is that they're expensive. Medicare, Medicaid, and private insurances do usually cover these for diabetes. Medicaid and Medicare do not cover them for weight loss. And so this is where it sometimes gets tricky with our value-based care and diabetes measures. So let's say you have a Medicare patient that comes to you and they don't have diabetes, but let's say they have pre-diabetes and they have a BMI of 40 and they want to lose weight. Well, Medicare is not going to cover the weight loss version. And so for the meds and brand names, those are Zepbound for tirzepatide, and then for semaglutide, that's called Wegovy. Medicare is not going to cover that. So for this person sitting in front of me, they have prediabetes, they have a BMI of 40, I may prescribe Mounjaro or Ozempic. When I do that, it's going to put them into the diabetes measure. The popularity of these drugs, understandably so, because again, they're some of my favorite drugs, have made it where there are drug shortages, which has affected our medication adherence to diabetes drugs this year. So, it's come with a lot of just interesting things that have happened culturally. If you are a TikTok user, a TikTok user, you've probably seen these drugs there. I think Elon Musk said he was taking Ozempic. They really become somewhat of a cult phenomenon. For our Medicare folks, because of the price, this is also somewhere we just need to be mindful, and I'm going to talk more about that in the next section. But when we think about some of the things we just need to be aware of, there is, in rats, there has been shown to be an increase in thyroid C-cell cancer. It's called MTC. It's actually never been seen in humans, only in rats and at higher doses, but that's usually part of the intake form, right? We'll ask if you have any family history of thyroid cancers. There is an association with pancreatitis, and I was really careful to put association here and not causation, because people with diabetes usually have high triglycerides and are usually at risk for pancreatitis anyway. But if you have a patient that has chronic pancreatitis or a history of recurrent pancreatitis, probably wise to avoid these medicines. Gallbladder disease, these medicines can cause some pretty significant weight loss. And as with any rapid weight loss, you need to be thinking about gallbladder if people are having, stomach issues. And then I just go ahead and tell people, when you start these medicines, about 50% of people are going to experience some degree of gastrointestinal side effects, nausea, vomiting, diarrhea. Usually we start at really small doses and titrate up. Usually the effects are temporary, and so usually after a few weeks they get better, but there are things that we can do and counsel our patients on to make those side effects better. So eating small meals. When you're full, stop eating. That's one of the ways they work, right? Is they help you know that you're full. Fatty foods, spicy foods, and then you can even slow down the titration. So a lot of them have a titration plan of increasing every week or every month, depending on the drug, but there's no harm in going slower. Like, you can always go slower. And so at this point, I will address Catherine's. Would love to hear your thoughts on compounding versions like semaglutide with B6. So what has been happening is, because the weight loss versions, like Wegovy, which is semaglutide, that's the FDA-approved obesity GLP-1, is not covered by a lot of private insurances and not covered by Medicare and Medicaid. A lot of people, want the benefit from these medicines, but their insurance doesn't afford it. So there are lots of compounding pharmacies out there that can compound these or make these medicines and make them less expensive. So maybe instead of $1,000 a month out of pocket, now it's $200 a month. The problem with those compounded versions is that in the history of compounding pharmacies in the US with medicines similar to this, it's easy if the compounding pharmacy is not following guidelines and procedures to have contaminants. Sometimes they use different salt forms or slightly different forms of the drugs that haven't been FDA approved. And so for me to endorse them, I can't endorse them. However, I will say that I'm empathetic and understand people's desire to have this treatment and therapy, because I think it is a game changer. I think in the US, we struggle with the pricing of it, though, because when you look at it purely from a pricing standpoint, and you take out the patient, which, we don't do that, but if we looked at it purely from a pricing standpoint, the way these drugs are priced in the US right now for weight loss specifically, you don't get your return on investment. And so when you think about the lifetime of a patient and being on these medicines and paying $12,000 a year, the return on investment is really not there. When you go to another country where the pricing is very, very different, then you do get your return on investment. So I think so it's going to be interesting to see what happens over the next few years, because I love these medicines because they have all those other good benefits. I do think they're game changers. We're just going to have to keep an eye on the pricing and see what happens. So as far as compounded versions, the issue is that you can't really guarantee the purity of them or just the safety of them. I anecdotally have heard of people who have taken them and had success, but I don't have a particular like compounding pharmacy I could say, oh yes, you should use this one because it's a good one. Next slide. Okay. And so for these, very effective. Usually you have about a 2% lowering of your A1C, no low blood sugar. Again, that's because they're glucose dependent. Oh, actually, I'm sorry. We switched gears here. This is our GIP GLP-1 agonist, tirzepatide. And when I first saw this medicine, I was confused because I was like, oh, it's a GIP and a GLP-1 agonist. Why are there not two drugs in this one? Because it's actually because tirzepatide, the only one in this class, right? Mounjaro is the diabetes approved version. The weight loss or obesity version is Zepbound that just came out. This particular hormone or molecule actually hits both. It's an agonist for both those receptors, which is pretty cool. So you have one drug that hits both. No hypoglycemia, again, because these are glucose dependent. Weight loss, very high. So usually at like for this one, the 12.5 milligram to 15 milligram dose, which is some of the maintenance doses, you have people who are losing, 25% of their body weight and maintaining it. So pretty amazing there. As far as heart benefits, kidney benefits, still under investigation. It's such a new medicine. They just really don't have that information yet. I'm imagining it will be the same as some of the just pure GLP-1s where there is some sort of benefit. Again, you got to think about people who have baseline kidney disease, because if they're getting dehydrated, you can cause a bump in their serum creatinine. So you have to make sure you're telling people to hydrate well, drink water, take fluids. Next slide. So again, this one, Mounjaro, Zepatide, tirzepatide, very similar to just your plain GLP-1, sort of the same counseling points. Thyroid, making sure there's no family history of thyroid cancer. And it's a very specific type, again, only has been seen in rats. Looking out for patients with history of pancreatitis, making sure if they're losing weight, you're thinking about their gallbladder. And then again, those side effects are related to the GI issues, nausea, vomiting, diarrhea, and just making sure we're doing everything we can to minimize those. All right, so now we've talked about all these great drugs that would be amazing if we could get them for our patients. But after we send the prescription in, what happens? So we're going to think through, how do we access these medicines? How do we help people with adherence? And then how do we monitor them? Okay, so my next question, kind of a trick question. All patients with diabetes should regularly monitor their blood glucose levels at home. True or false? So I put this question in here because I knew it would be controversial. So as we talk through this section, I'll tell you what the guidelines say, and then I'll tell you sort of my practical recommendations. So it looks like we're going to land at probably like a 50-50. All right, next slide. I like to start with this slide, especially when I'm talking to frontline providers, and especially when I've done presentations to medical residents and faculty physicians before. There have been surveys. This is just one survey. It is not unique, right? Most surveys say this. When they talk to older adults, 2/3 had difficulty affording their medicines, didn't tell their physician. 66% of those said their doctor did not ask about affordability of medicine. 58% thought that the physician probably couldn't help them anyway. And then about 50% were embarrassed, and so they didn't even ask. So I always share this slide because my point is, anytime we're prescribing medicines, especially for diabetes, COPD, where we know they're going to be expensive, I just say, hey, a lot of times I'm going to prescribe this medicine for you. A lot of times it's really expensive. It wouldn't be, unusual if you get to the pharmacy and you're surprised by the cost. If that happens to you, call me and say, I'm having some trouble with the price of this medicine. Let me, is there a way that you can help me? So I just actually start the conversation when we send in the prescription to sort of normalize it. And then, so here, my point is always just to ask, just kind of make it part of the conversation. Next slide. When Shannon was talking about health literacy and understanding things related to just the medical world, I automatically thought to this slide. This slide is super confusing. I even have a hard time explaining it. But what this is meant to illustrate is that for our patients that have Medicare, there is something called the coverage gap or donut hole. And so on here, it's referred to as the coverage gap. They have been talking about getting rid of this coverage gap or donut hole, gosh, since I was in pharmacy school, which has been over 15 years ago now. Because what happens is like, let's say we have a person that has heart failure and kidney disease, and they have diabetes. So let's say we put them on a GLP-1, we put them on an SGLT2. Well, you all saw the prices for those. What happens is because of that initial coverage and the deductible, a lot of times those patients are going into the coverage gap. When they go into the coverage gap or the donut hole, you can see here sort of the price that they have to pay. So if you look at the orange sections and you look at the coverage gap right before you get to the out-of-pocket spend threshold, they're having to pay 25% currently. Now, 25% doesn't sound like a lot, but when the medicine costs $1,000, like a Mounjaro, they have to pay $250. And when we put them on expensive medicines, even though they're the best medicines for the patient, we speed up the process by which they get to that coverage gap. And so, especially for our Medicare folks, talking about the drug cost, talking about affordability is important. Now, luckily, a lot of the drug companies will actually give these medicines to our patients at no cost when they're in that coverage gap. But again, we got to know the patients are having trouble with the medicines before we can do anything about it. Now, fast forward to 2024, 2025, you can see there that the deductible stays the same, but there are some changes in when catastrophic coverage kicks in. When that kicks in, they're fully covered again. So there are some changes, but with the Part D benefit structure, but the point is, I don't really expect it to change significantly to where these medicines are affordable year-round for all of our patients. So if you're in a CHESS contract, this is a great place where the pharmacy team could help your patients. Next slide. Okay, so I'm also thinking about Shannon's lecture. If I could have y'all remember one thing, it would be low-income subsidy. And so thinking about her lecture, I should put this way in the beginning, but when I think about getting access for patients, if your patient has Medicare and they have trouble affording a medicine, regardless of what the medicine is, the first thing they should be assessed for is something called low-income subsidy or extra help. It is a federal program offered through the Social Security Administration. You can see the link here. It's a relatively quick application online if someone can help the patient do it online. That says whether or not they're at an income, and usually it's like 150% of the federal poverty level to where they may be eligible for this extra help. Not only does it help them with their prescription copays, but depending on their income level, it may help them with their Part B premiums as well. And so that's what they pay, monthly to go to the doctor's office. So it can save your patients thousands of dollars if they're eligible. And a lot of folks in North Carolina are, and they just don't know it. The other things that we can do that I've mentioned are those patient assistance program applications through drug manufacturers. Low income program only for Medicare age. Yes, unfortunately. So when you think about our commercial folks who have exchange insurance through the ACA, those are hard folks to help with med access. And so low income subsidy is only Medicare. Okay. I'm not going to spend a lot of time on this slide, but when you think about we prescribed it, we're able to get it for them through their insurance or manufacturer. Now we have to make sure that they take it. So these are some key things that we can think through to make sure patients are able to take their medicines. Cost, if it's more than $10, they're 2.6 times more likely not to be adherent, right? Or I'm sorry, it's the opposite of that. If it's low cost, less than $10, they're 2.6 times more likely to be adherent. Access to pharmacies. When you're thinking about just transportation, social determinants of health, this is why we really encourage people to do 90-day supplies. If they want to use a mail order pharmacy, that's great. Some pharmacies also deliver, some local independent pharmacies. So there are some things we could do to think through how do we remove those social determinants of health barriers. Regimen complexity. So this is interesting, right? Adherence for once daily dosing, 79%. Twice daily dosing, 66%. 3 times, 38%. I don't know how many of y'all have been prescribed antibiotics recently, but for me, if they're more than twice a day, it's just really hard to remember to do those. Mental health. So, we've talked a lot about sort of specifics around the diabetes medicines, the diabetes care. But if we have someone who's depressed, that creates a whole different sort of circumstance that we're working with, related to adherence and just self-care. Age. So people less than 65 are more likely to be non-adherent than those of our Medicare age. And then when you look at patients with diabetes, one of the most common reasons they're not adherents is because adverse effects. So this particularly resonates with me with metformin. So a lot of people have GI side effects from metformin, and that's why anytime y'all have a prescription and a patient that has metformin, I always encourage, to do the slow titration up. We're in this for the long game, long haul. We're not in it for the short term. So always slowly titrating those medicines and letting people know what to expect. Like, hey, you're probably going to have some side effects from this. Maybe you'll feel a little nauseated, have some diarrhea, but it will get better, and here are some things you can do to help. Again, these are things that I know y'all know. Adherence, thinking about the impact of, why it's so important. Not only does it improve the A1C, decreases trips to the emergency room, hospitalization, lowers healthcare costs, and ultimately at the end of the day, it helps people live longer, healthier lives. As far as adherence goes, here are some best practices. Tell people why they're taking their medicines. Tell them how long to expect to take it. I used to work in a heart failure clinic, and I remember people would get discharged on, a 30-day supply of their Carvedilol, and they would come back. They're not taking it anymore. And I'm like, oh, why are you not taking this anymore? They're like, well, I finished the day's supply, or my blood pressure's good. So really explaining to people, and this goes for those diabetes medicines too, right? Like, we're trying to lower your blood sugar, yes, but when your A1C is controlled, you have to take this, ongoing to maintain that control. Or let's say they're on something like a Farxiga, which is an SGLT2. You're taking this because it also protects your kidneys and improves your heart failure. So just clarifying the duration of therapy, clarifying exactly why they're taking it can be helpful. I found that especially true in the heart failure world. Like, yes, it's a blood pressure medicine, but it also helps protect your heart muscle and strengthen your heart muscle. I'm talking about those side effects up front. We've talked about the 90-day prescriptions, mail orders, or mail, delivery. And just thinking about like value-based care, one of the things that can be really helpful when we're providing good care is to actually just document the care that we're providing. So for example, if you have a patient that's taking metformin, 500 milligrams, 2 tablets twice a day, but they're not really taking that because they can't tolerate it, send in a new prescription to the pharmacy. Send it in for what they actually are taking, right? The 500 twice a day. That actually helps us document the good care we're providing and helps us meet some of those quality measures. Cost of medicine, just ask, make it part of the conversation for disease states that have expensive medicines. Next slide. We'll spend a little bit of time on this because we have just a few minutes left, but I just want to talk about some blood glucose monitoring best practices. So A1Cs, even if someone is well controlled, The guidelines say we should do that twice a year. If they are not well controlled, we should do it about every 3 months. And as y'all know, we don't do it more frequently than every 3 months because an A1C, measures the sugar coating or the glycosylation of those red blood cells. The red blood cells have a lifespan of about 90 days. So that's why we don't do it more frequently than every 90 days. I will say at my previous practice, it was a struggle to get people to check A1Cs twice a year and people who are controlled because they're like, their A1C is 6.8. Why do I want to check it again? But I think being in the habit of trying to do every 6 months actually can help us just provide timely patient care and also helps with quality measures. Next slide. Okay, so here's the controversial slide. So this is straight from the guidelines. So for people who are on insulin, blood glucose monitoring should be encouraged when appropriate based on their insulin regimen. So depending on the insulin regimen, it varies. When you look at the end of this quote, there is a B. So B means it's kind of the level of evidence. So, there's A, B, C, and then we skip to E. So B means there's pretty good evidence to support that. So if they're on insulin, yep, they should be checking their blood sugar. Look at the next one though. Although blood glucose monitoring in individuals on non-insulin therapies has not been consistently shown to improve A1C, it may be helpful in altering diet, physical activity, or for managing medicines. So I think the days when someone first gets diagnosed with diabetes and we give them a glucometer and we say, check your blood sugar every day, I think those days are kind of outdated at this point. What I think can be really helpful and what I recommend, especially if people are on regimens that don't cause low blood sugar, is something called testing in pairs. And it's really to give your patient insight into how their actions affect their blood sugar. So for example, let's say that Miss Smith really wants to go to IHOP and have a pancake breakfast with her family. And she's like, I wonder how this is going to affect my blood sugar. What you should encourage her to do is test in pairs. She checks her blood sugar before she goes in. And then after the first bite of food, she times it for about 2 hours and checks it 2 hours later. And that testing in pairs, having the before and after, can give you an idea of how your body responds to that particular food or that exercise or that new medicine. So testing in pairs can be really helpful when you're trying to test a change in your lifestyle. So do all patients need blood glucose monitoring? Probably not. But it's been kind of like aspirin, right? Like aspirin for primary prevention. It's something that we've done a long time. It gives people like a tangible number to react to. And so I'd always advocate for more testing rather than less testing, but it may not be as necessary in all patients. Next slide. Okay, so I'll just talk a little bit about this because this could be a whole day lecture in and of itself. Continuous glucose monitoring. So think about your Freestyle Libres, your Dexcoms. These have been game changers for patients that I've worked with because it does give them real-time feedback on what their blood sugars are doing. And so for people who are on multiple daily injections, or now even basal injections, so that 1 time a day insulin, Medicare will cover that and most insurances will. Next slide. And so this is the kind of report that you get back from that. And so you can see the green here is the time they've spent in target. You can see the red is when they're too low, and then the yellow there is when they're too high. And so you can print that out, and it even gives you an estimation of what their A1C would be. So you don't even necessarily have to check their A1C in that moment because this is providing sort of real time of what it could be. Or actually, it's probably even better because it's telling you, over the past, month or whatever, they've checked it, sort of what their A1C would be if you were to actually do like a point of care or a blood draw at that point. Next slide. So then it's like, okay, what do I do with this continuous glucose monitoring? So luckily the ADA actually has some pretty specific guidance on that. So in general, for someone's time and range, so let's say you want their blood sugar to be no lower than 80, no higher than like, let's say 150. You want that time and range to be about 70%. Below range, you want that to be less than 4, and then less than 54, less than 1%. Now, if you have an older adult 85 years old, they're frail, you can loosen up on that some, just like you loosen up on their A1C goals. And so when you're thinking about time and range, we actually say 50% is acceptable, less than 1% below range. And so really up to 50%, you could have them running high as long as they're not symptomatic, because we're really just trying to prevent falls and adverse effects from happening. Okay, next slide. All right, we're going to skip these 4 just for the sake of time, just these questions again. But thank you for listening. And so just to recap on the answers though, so the first one, smoking cessation, actually has the most mortality benefit in diabetes. For the second one, metformin is not necessarily first-line therapy anymore. However, it's cheap, it works really well. But when you think about folks with heart failure, with kidney disease, with cardiovascular risk, there are ones that are more beneficial. And then tirzepatide does all the above, pretty much does all the things. And then do all patients need to check their blood glucose? Probably not, but it does have a place, and it's really informative for the patients to see how their actions affect their blood sugars. All right.
Well, thank you, Rebecca. That was awesome. That was so informative and so helpful. Our final presenter today is Dr. Kim Basutti. Dr. Basutti is an amazing practicing physician at Conover Family Practice and has served as the Senior Director of Clinical Operations at Chess since February of 2022. She earned a BA in chemistry and a BS in biology from Florida Atlantic University before earning her Doctor of Osteopathic Medicine from Nova Southeastern University. Dr. Basutti served her internship and residency with the Duke Southern Regional AHAC Family Medicine. She is a North Carolina Board Certified Family Physician. As a practicing physician, Dr. Basutti has a unique perspective on falls, risk assessments, and prevention of injury. Her presentation will cover who is at risk for falls, strategies for fall prevention, and falls risk assessments. May I present Dr. Kim Basutti.
Thank you, Thomas. I just want to shout out to Shannon and Rebecca for what a wonderful job they did. They are part of my team, and I'm just really proud to be on that team with them. So thank you to them. Today, we're going to talk about falls and fall risk assessment. The objectives are: what is the definition of falls? Who is at risk for falls? Why is preventing falls important? What are the different types of fall risk assessments, and what can be done to prevent falls for those at risk? So I like to start with a patient story. I think it grounds us and kind of gets us all on the same page. And of course, I do see patients in the clinic. I do work in a clinic 2 days a week, and then I work with Chess 3 days a week. So in my clinic setting, I had a patient about 2 weeks ago named Joe. He is 87 years old, and when he came into the office, it was just for his routine checkup. It wasn't a well visit. It was just his 6th-month follow-up. He lives in an assisted living facility with his wife. When he came in, I noticed he likes to wear a back brace. It just gives him a little stability, and he uses a walker. He didn't have any history of falls. He does have a history of bladder cancer, degenerative disc disease, diabetes with neuropathy, and he's on a long list of medications. What prompted me to kind of look at that is when he came in, he does follow up with the pain clinic. And I noticed that his pregabalin or Lyrica was increased from 75 milligrams twice daily to 100 milligrams twice daily. Sort of prompted me to take a little bit closer look at his medication list, because that's a pretty big dose for this gentleman, and especially with the other medications he's taking. So he's also taking Cymbalta or duloxetine, metformin, atorvastatin, and temazepam to help him sleep at night. When we went over his blood work, his hemoglobin A1C was 6.2. So one of the things I noticed too with Joe is, and especially patients in this age, they start to accumulate medications. They also start to accumulate doctors. So each doctor is giving them something to solve a problem, and that's what the patient is looking for. What they don't understand is sometimes, and sometimes the providers don't either, is some of these things start to work against each other. With Joe, he thinks every doctor's trying to help him, and he's just taking the medication. So I really wanted to, as a primary care physician, as a family doctor, I just wanted to look at the bigger picture and make sure that these medications are appropriate for him. So first I started with, the medication pregabalin was increased. So I left that one alone. We'll see how that goes. But I talked to him about the Cymbalta. With Cymbalta, we started in my clinic with him to help with pain management because Cymbalta or duloxetine can help with depression, anxiety, and pain control. Since the pregabalin was increased, I started talking to him about it and explained to him, do we really need all of these medications? Are you willing to really take a look at this and start taking some things away? Because it may be that it'll increase your risk of falling. So he was in agreement. It's like, yeah, I like the idea of taking something away. So we did actually, we're weaning him off of the duloxetine. He felt like, I'm not really depressed. I haven't had any depression or anxiety. I think we can try to take that away. The next thing I looked at, and Rebecca alluded to this sort of at the end of her lecture, is his A1C. As an older adult and an elderly man, I can look at his A1C and say, do I really need to have that strict control of it? And the American Diabetes Association actually says that if the patient is at a higher risk, that they're very complex or in poor health, their A1C goal can be less than 8.5. So I had him very strictly controlled, and I talked to him about maybe it's time we start backing off your diabetes medication. He's only on metformin, so honestly, I just stopped it. He's very good about checking his blood sugars, and so he's going to let me know. And believe it or not, this 87-year-old man knows how to use a portal. He will message me, and he does. So don't think that just because they're elderly that they won't use the portal system that we have in some of our EMRs. This gentleman will use it. So yes, I agree. So we made a plan that if I stop it, yes, you're going to keep an eye on it, and you're going to message me if you're having any issues with your blood sugar. So we stopped the metformin. The last thing, and I don't know how I let this one go by for so long, is that he was being prescribed by me temazepam to help him sleep at night. That was a little bit more of a struggle to kind of talk him out of that one because he had been on it forever. So what I did was talk to him about sort of the risk factors for him being on this medication. And I will talk more about this as the lecture goes on. What I did in this situation with him is I'm weaning him off the temazepam, and I started him on a medication called trazodone. We talked about how that'll help him sleep, and if there are some depressive symptoms that could potentially come back because we stopped or are weaning from the duloxetine, then maybe I'll capture that with the trazodone as well. So we made some changes, hopefully to try to improve his steadiness and prevent him from falling. And I'll refer back to Joe as we talk. So what is a fall? And there's all kinds of fun definitions out there. I probably could have put 12 on here, but I chose the World Health Organization definition for a fall. It's an event which results in a person coming to rest inadvertently on the ground, sorry, that should say ground, or floor or other lower level. So pretty much what we can envision when someone falls, they didn't mean to, they were standing or they were upward and they landed in a lower position than they were intending. So statistics are a lot of fun. I like to throw them out. Hopefully your eyes won't glaze over, but it's kind of nice to know, why is this even important? Why do we care about falls and fall risk? It is the second leading cause of unintentional injury deaths worldwide after road traffic injuries. In the United States, falls are the most common cause of non-fatal injuries for people that are over 65 years of age. Females fall more than males. However, men are more likely to die from fall-related injuries. As people get older, their fall risk increases. And up to 32% of individuals above the age of 65 will fall yearly in the community. So I wanted to point that out because that's not the hospital and that's not the nursing home. That's just in their homes. Fall-related injuries are the most common cause of accidental deaths for those that are over the age of 65 in general. And then some statistics that kind of give us an idea of the cost of falls and hospitalizations for falls. Fall-related injuries account for about 15% of rehospitalizations in the first month after discharge from the hospital. And I know a lot of the work that our care coordination is doing within CHESS and with our value partners is trying to prevent rehospitalizations, but fall-related injuries are something we need to be paying attention to. So the total estimated cost for non-fatal falls is anywhere from $16 to $19 billion per year. It's a lot of money. And as an accountable care organization and working with value-based contracts and the work that we're doing, that's the kind of money we want to try to save for the system and for our patients. The total estimated cost for fatal falls is $170 million. There are two types of fall risk, and I think of it as, I think it's pretty easy to remember because intrinsic fall risk means it's within the patient. It's something that's happening within the patient that will increase their risk of fall or the type of falls that they have. And then extrinsic is something outside of them. It's in the environment. So a couple of examples for intrinsic risk. Orthostatic hypotension, it's really common in the elderly just by virtue of getting older, but then you throw in the blood pressure medications that we are titrating up on them, and then you can actually cause them to fall. Limited endurance, so our patients who aren't very active and they cannot go very far, walk out to the mailbox, they just can't make it, they get weak and they fall. Impaired vision, again, kind of inherent to getting older, but if the vision is failing, if they have cataracts or any kind of eye diagnoses, that could impair their vision and they could trip on something and fall. And then alcohol use is another one where, believe it or not, our elderly patients are turning to alcohol more and more. So extrinsic could be something like poor lighting in their home, clutter, slippery floor. They can have an uneven threshold. So we're thinking about what's going on in their home. And then caregiver support or lack thereof. Maybe they just don't have the help that they need in their home. Other things to consider, and this is something that you saw with Joe, is the use of benzodiazepine. So he was on temazepam to help him sleep at night, and that increased his risk of fall. That would be an intrinsic risk. If a patient is using 4 or more prescription medications, so even Joe's list, and that wasn't all inclusive, he is at increased risk of fall just because of that medication list. And then the muscular strength or range of motion impairment. He walked in with a walker and a back brace. So all of those, just looking at him when he walked in the building, I can see that that's an issue. Of course, comorbidities can also increase risk of fall, like diabetes, foot ulcers. We talked about neuropathy with him, stroke, syncope, anemia, Alzheimer's, Parkinson's. Vitamin D deficiency. Now I want you to kind of keep that in your mind because when I started to put this together, I thought, well, how does that affect risk for fall? I can see where it can affect risk of injury because maybe a patient will have weakened bones, osteoporosis. But believe it or not, and we'll talk about it again later, this can actually help with muscle strength too. So if they have vitamin D deficiency, they may have weaker muscles. If they have glaucoma or cataracts, and then believe it or not, with patient characteristics, the fear of falling can actually increase their risk of fall. It's kind of like a self-fulfilling prophecy. The fear itself is going to create the situation. So fear of falling, and I have patients like that. Some of them don't want to get on the table in my office because they're afraid they're going to fall. Gait problems, impaired ADLs, frailty, inability to follow instructions. So you have that patient who their daughter brings them into the office, but they're telling them, Mom, sit here. Mom, don't do that. Mom, put your foot here. And they're just not able to follow those instructions and then adapt to a changing environment. Just coming into my office sometimes throws them off a little bit. And then, of course, recent hospitalization, which is something that our nursing staff is very attuned to, is that you're taking care of these patients as they're coming out of the hospital. This is a perfect opportunity to kind of assess their risk factors for fall, and maybe we can help to put some resources around the patient to keep them from falling and then being re-hospitalized. So we talked about risk factors for fall, but what about risk factors for injury? So there's going to be patients who fall. We've probably all fallen. We have dogs that we've tripped over. There's that one day where we get ice and we slip. So, falling is not uncommon. However, what is the risk factor for injury? So once I fall, how likely am I to have an injury result from it? There are some predictors of injury or fracture. Of course, women are more likely to fracture than men. Patients that are over the age of 75 are more likely to have an injury. White race, BMI of less than 22.8, so my skinnier people, history of a stroke are more likely to have an injury from a fall. If they have cognitive impairment, my patients with Alzheimer's disease, dementia, one or more Rossau-Breslau impairment. So that is a mouthful, but basically there's three components to that. A patient is, if they have one or more of these impairments, they would be unable to walk upstairs, unable to perform heavy work, and that can include things like sweeping, mopping, carrying a load of laundry around their home. Or now, if they can't do all that, I'm sure they're not able to walk a mile, but walking a mile is one of those characteristics. And then if there's use of anti-epileptic drugs, so things like Dilantin, for instance, if they're using those medications, they're at more risk for injury. Things also to consider if they've had a previous fracture, and then if they've fallen in the past year, they're more likely to be injured with a fall. So what I'm curious about though is what are those patients that if they can injure, we don't want that, but who are the ones that are at most risk of death or mortality from a fall? The most common is a head injury with a fall, and they're taking an antiplatelet medication. So you can imagine that they would have some type of brain bleed associated with the fall. That's more likely to result in a death. If they're frail, and later on in this discussion, I'll talk about frailty and how we assess that within CHESS and how we're encouraging our value partners to assess frailty so we can get ahead of some of this. Advanced age, so the older the patient. And then we talked about this already, but white men over the age of 85 are more likely to die from a fall versus a female. And then again, the BMI of less than 22.8. So I'm talking to you guys about this because the fall preventions falls on the nurse. And this is true for both inpatient and outpatient. For those of you that are doing inpatient or have done inpatient, you're the experts on this, and you know that falls and fall-related injuries are associated with the quality of nursing care in an acute care setting. So the hospital system and the nursing system is being graded on this. It's a nursing quality indicator, and it's monitored by the American Nurses Association. So these patients that falling in the hospital, those kind of statistics are falling on the nurse. In the outpatient setting, the patients, less than half of older adults aren't even telling us that they've fallen. They're certainly not telling me, and maybe they're telling you guys because you're the ones that first walk in the room and you're the ones asking that question. So we have to ask them. If they're not going to tell us, we have to prompt them and we have to get them to speak up and let us know if they're falling. For patients that are over the age of 65, we need to ask them at least once a year. And it's really one of the best times to do it is during the Medicare well visit. Are you falling? Have you fallen? And kind of decide if there's a risk for fall there. Fall screening is a quality measure in the Medicare Shared Savings Program, and that's part of our accountable care organization. And for patients with a history of falls or at risk for falls, we want to really find out who they are and then have a more comprehensive assessment. What are the risks? What are the risks? And then what is it within the patient that is causing that risk? And then we want to refer them to the appropriate resources. So is that physical therapy? Is that home health? That's what we're going to determine. So I'm going to split it up a little bit into inpatient and outpatient. Mostly my talk is going to be about the outpatient setting because that's where a lot of us are. But in the inpatient setting, a little bit more statistics. It is the most common adverse event in the hospital setting. Anywhere from 700,000 to 1 million patients falls occur in the U.S. hospitals, resulting in about 250,000 injuries and 11,000 deaths. 2% of hospitalized patients will fall at least once during their hospital stay. 1 in 4 falls result in an injury. And so all of this to say that this is a big issue for patients. It really does affect them. It increases the risk of injury, mortality, and decreased quality of life. Because even if it could result in an injury that then impacts them later on. And for the hospital, of course, we look at the expense of this. It is increased length of stay, cost of care, and even lawsuits. And most importantly, Medicare stopped paying for falls that occur in the hospital and fall-related injuries in 2008. So we're going to talk about some fall assessment tools. And I do split this up. So there's tons of them, guys. And I kind of grabbed the most common and I've split it up into inpatient and outpatient. And one of the questions I had when I was making this is like, what's the best one? And I looked, and honestly, there's lots of data on all of them doing a good job. So I think of this as more like when my patients ask me, what's the best diet? And I say the one you stick to. You know, what's the diet that you stick to? Because they all can work in their own way, but we have to use them and stick to them to see results. So the 3 inpatient ones that I'm going to talk about, and you guys in the back of your mind, think about ones you know about or the ones you are utilizing now in your healthcare systems, because I'm gonna do one of those polls too and see which ones you guys are aware of or using. So the first one, the Johns Hopkins Fall Risk Assessment Tool, the Hendrick 2 Fall Risk Model, and the Morse Fall Scale. The Morse Fall Scale, I believe, is the one that we're using with an atrium wake, and then we're using a truncated version of that in the outpatient setting. All right, so lots to look at here, but I'll try to make it simple for you. This is the Johns Hopkins Fall Risk Assessment Tool. This seems like a really common one that's utilized. It really does split the patient into high risk and low risk. And it's a lot of questions. And so you have to go through this list and kind of add up the points and things to bring to your attention. Of course, we've already talked about age, the history of their falls. For this one in particular, they talk about elimination. So are they incontinent? Because if they're incontinent in either urine or bowel, they're at increased risk of falls. We've already talked about medications, so that's on here too. You assess the patient and the medications that they're taking. Another one that is in here that's to be brought to your attention is if they have anything kind of attached to them. So if they have IVs, a chest tube, catheters, anything attached to them, that's going to make them a risk for fall while they're in the hospital. If they're using any kind of mobility devices or they're unsteady, they have visual impairment, and then their cognition. So if you look at the list, thinking about patients that you've taken care of or ones that are coming out of the hospital that you're assessing and doing evaluations on, that doesn't take much to sort of add up points here to make a patient a fall risk. Oh, is there something in the chat? I'm sorry, I wasn't paying attention, guys. Oh, no. Okay, sorry. And please, I am a mother of a preteen and a teen. I am used to being interrupted. And so feel free to interrupt me if you have any questions or anything you want to ask or even comments that you have. So the Morse scale is the next one. And this one is kind of interesting because it's like giant numbers. So if you looked at the Johns Hopkins, it was like onesie, twosies, and you add them up. Well, these are like giant numbers, 25, 30. So the number gets high pretty quickly. History of falls, ambulatory aids like the crutches and walkers, the IVs, gait abnormalities. They do not take into consideration medication on this one. So that's something that's a little bit different about the Morse fall scale. And then the last one, the Hendrick 2 fall risk model. This one's interesting because they actually, and I'll talk about it when we get into the outpatient setting, but they utilize an outpatient fall risk assessment called the Get Up and Go test. This one seems a little bit hard to do in the inpatient setting, but maybe not. I mean, I have not utilized this myself in the inpatient setting. So let's talk it over. This one's different because it talks about depression and dizziness, which was not necessarily on the other ones. They give an extra point if the patient is male, which the other ones didn't necessarily do. That was more age related. For this one, the medications do factor back in again. The Get Up and Go test, I'll talk about a little bit more, but this one is one where the patient has to get up and be timed as they ambulate a certain distance, turn around, come back and sit down again. So in my mind, as I'm thinking about it, some of my patients that have been hospitalized, myself who has been hospitalized before, that may not be something that's easily assessed depending on the situation, whether they are on a medication, whether they have pain control or surgical processes that have been done. So this one might be a little bit more difficult to do, but it's a possibility, and you all may have had experience with that as in the hospital setting. I think you don't have to go back, Megan, but I just think what I like about this one, or the one we just saw, the numbers are small. I don't know why that seems to be a thing for me. Like when the numbers are really big, it doesn't make sense to me. Why do we go from 0 to 25? So that one I liked because the numbers were smaller. Sorry, that's just a math thing, I guess, for me. All right, so for the outpatient setting, there's 3 that I talk about here that I mean are very common. Timed up and go test, 4-stage balance test, and 30-second chair stand. And these are all ones that are really commonly used in the outpatient setting. So we'll go through each of those as well. Okay, so we talked about the timed up and go test. This was part of the Hendrick 2 fall risk model. All right, so this is a nice handout. This is from the CDC. I love it because everything's on there, and it's a one-pager and it can be filled out in the office. I'm sure there's ways that we can incorporate this into the EMR as well, which I really appreciate as a provider, and I'm sure my nurses do as well. When it's already in the EMR, you pull it up and you mark your answers, and then everyone can see it. So for this one, you got to have a chair, and the patient has to be able to stand up and walk. No assistive devices. So they have to stand up from the chair, walk to a line that's about 10 feet away, turn around, come back and sit down, and they're timed. They have to be able to do that within 12 seconds. I have not tried this. I think I should have before this lecture to see how quickly I can do it. Hopefully I can beat it, but that's important to beat it within 12 seconds. If they can do that, then they are not at risk for fall. The 4-stage balance test, this one's a little bit trickier. So the patient doesn't necessarily have to walk, but they have to be able to hold their position. I know the fella in their picture is walking, but that's not quite what this one is about. If you look at the right side where it shows the little shoes, the first thing they have to do is stand with their feet side by side, okay, like this. And then you make them stand there for 10 seconds. If they can't do it, you put the amount of time that they can, but at least 10 seconds. Then you want them to move that foot, sort of the one foot at the instep of the other foot, and then hold that for 10 seconds to see if they can balance with that change in position. And then the harder one is putting one foot in front of the other like that and having them stay from heel touching the toe and then timing them to see if they can balance. That one's tougher. And then lastly, this one's probably the toughest of all, is, go back one more time, I'm sorry, is that they have to stand on one foot and their time to see how long they can stand on one foot. Okay. So the third one that I'm going to talk about is the 30-second chair stand. This one is a workout, I'm not going to lie. And so as I think about which patients to try this on, they cannot use assistive devices for this one either. So this is probably my patients that maybe I don't think that there's much of an issue, but maybe they are when I talk about EFI in a minute, I'll kind of point this out. There are patients that I can eyeball and say, oh, this one doesn't, they look frail. I really need to watch this one and maybe really need to dig in to see if they're having some issues with their gait or their balance. And then there's some patients that are pulled because of a higher EFI, and I'll talk about that, where I wouldn't have maybe seen it in them, but the statistics are showing me that they're at high risk for frailty. This might be one that I would utilize on them because maybe they're not using an assistive device. They look like they're in pretty good shape, but this might show me that maybe they're not. So this one, when I say it's a workout, is that they have to sit down, not using their hands, and stand up as many times as possible within 30 seconds. So that's a pretty good workout. And then, of course, men and women are both scored differently, and you can tell if they have issues with their balance and their gait potentially because of their balance by how many times they can sit down and stand up within those 30 seconds. Oh, I don't know where that came from. I think that was Rebecca's. Okay, but you could answer it if you guys want to. So I think that was where my little Slido was going to be, where I was going to ask you guys which fall risk screening that you are aware of or that you have utilized. And you are welcome to put it in the chat if you want to, or speak up if you want to. I was going to have a little conversation there about that if you had some experience with any of those. Okay. All right. So I alluded to EFI. Here we go. I'm going to talk about EFI now. This is something that we really are excited about at Chess. It is utilized at Atrium Wake. It is the Electronic Frailty Index. It's a tool that we use to help easily and accurately identify frail patients. And so I talked a little bit about this eyeball test. When Joe walked in the office with his back brace and his walker, I could tell that Joe is frail. But there are some patients of mine who are very mobile and kind of trick me a little bit from a perspective of like just seeing them walk in and then, oh, that's okay. And then when I see the EFI, I say, oh, they actually are frail. So let me try to explain to you what that means. The definition of frailty is someone who has decreased reserve in both physiology and day-to-day function, leading to a vulnerability to acute stressors. That eyeball test, we're only about right, we're wrong 40% of the time. So we're not really good at it, figuring out a patient's frail just by looking at them. The EFI is a tool that is embedded in our EHR and our EMRs, and it really pulls data from a lot of different places to sort of spit out this number that tells us how frail a patient is. It uses about 50 different data sources, and it can be medication list, function, medical diagnoses, their weight, remember how much BMI kind of factored in before, their blood pressure, and even their blood tests. And it can predict worse health outcomes, including falls. It can including increased healthcare costs to the organization and mortality. And knowing that I like small numbers, the range is from 0 to 1. So that I like, don't know why. But fit patients, their EFI is less than 0.1. Pre-frail patients, their EFI is between 0.1 and 0.2, so they're kind of rising risk. And then our frail patients, their EFI is less than 0.21. So we've talked about this with your organizations, and some of them are thinking about utilizing EFI and plugging it into the EMR. Some of them have already started steps to do that. What I really like about this is it puts a lot of power in your hands as nurses and care coordination. And I'll talk about this in a second, but you can take this number and you can direct providers on how to care for the patient better. You guys serve this up to us so that we know, oh, wait, this patient is frail. I couldn't tell by looking at them. You're going to see the number and you're going to serve it up to me and say, you need to take a better look at this patient and assess them better for fall risk, or even do some advanced care planning. So at Chess, we are doing some pilots with this. And our clinical team, so you've already met Shannon, you've met Rebecca, we have a whole host of us on our clinical team, and we are really excited about working on getting advanced care planning, care models in place for our organizations. We want patients to be, when they are frail, in that pre-frail time, to start having conversations with their providers about what do they want their healthcare to look like? What do they want to be done as they're aging? And if they have unable to make decisions for themselves, do we have it in place? Do we have the paperwork done that says who is responsible for making those decisions and what is it the patient wants? It kind of puts the power back on the patient for end of life decisions. So within Chess, we use it for advanced care planning. During the Medicare well visit, if a patient has an EFI that's greater than 0.2, so they're in the frail state, the care coordination will make a recommendation to the provider to have an advanced care planning discussion. And I'll see this in my practice even before a Medicare well visit. I'll get a little message that says this patient is considered frail, consider having this advanced care planning discussion. And it really tees it up for me so that I can have the discussion with a patient who may not look frail when they walk in the door. And for pharmacy, so you've heard Rebecca talk, for pharmacy, the EFI is utilized to really start de-prescribing, especially for diabetics. So with Joe, when we saw that his A1C was well below 7, this would be a patient that the pharmacy can then make a recommendation to start taking away those medications. So I was already thinking like a pharmacist when I walked in the door, knowing how we are working in Chess, and I started taking away the medication. They can also start de-prescribing in general. So again, I was starting to think like a pharmacist at that visit, and I was taking away temazepam, and I was looking at the duloxetine and just trying to figure out ways that I can take away medications to help this patient from falling. And as care coordination and as nurses, you can always pull pharmacy in if you think that that's needed. You can also have an opinion about that, speak to the provider about the medications. Pharmacy, of course, can make those recommendations to the provider. So these are all, it's a tool to help guide care for patients that is really for all of us to utilize. So there's been success, and there's studies that show that EFI is helpful. I promise it's not like we're selling anything. This is just to be used. We don't have to, there's no financial thing here. It's just like we're using it to help patients and to try to get ahead. What I'd really love, I guess my dream, is that we all start putting our heads together and say, well, how do we impact patients otherwise? We have this pilot that we're doing within Chess to impact advanced care planning, but how do we start thinking about impacting patients by getting ahead? Do they need home health? Do they need exercise? Do they need physical therapy way before they start to have a fall? And so would that EFI be something that we could utilize to start making some of those other pilots come to fruition? So I'll be quick here because this is just a bunch of studies that have been done, and a lot of them are retrospective, kind of looking back at patients who've had surgeries or had an endoscopy. And they show that if a patient, by going back and looking at their EFI, if they had a high EFI, they were more likely to have be discharged to an acute care facility. They would be more likely to pass away. They would be more likely to come back to the hospital after a procedure. And one of the interesting things I think is sort of the last one is this preoperative risk stratification. So this is a patient that is taking an elective surgery, and you want to look at, is their EFI high? Are they going to have a negative impact after a surgery because they're already frail? And so they show that if it's a non-emergency surgery and they are frail, that they might actually have higher readmission rates, higher mortality. They may need more post-acute care needs to be met. So just looking at that EFI gives us an idea what that patient's outcome could be. And maybe we should make other decisions. If it's a non-emergency surgery, maybe that shouldn't happen in somebody who has a high EFI. So if if this is something that is interesting to you, speak with your your healthcare organizations. We are happy to support it. It's embedded in the EMR, like I said. You guys serve it up to provider during the Medicare well visits, and then we can get ahead. This is the part that makes me excited. It's like, how do we target these patients so we can get ahead and provide them services and interventions before we get to a problem, such as care coordination, home health, physical therapy, and our deprescribing efforts. So we talked about falls, how to assess patients for risk. So how do we stop them from falling? There's a lot of research about exercise. It's probably the most commonly studied intervention, and because it works, it is effective. Now, if you just say go exercise and a patient just goes and exercises, they get about a 14% reduction in falls, but that increases to about 37% or more if we target them for specific issues that they have that are causing their falls. So keep that in the back of your mind that we can go exercise, but if we target them with specific ways to strengthen themselves, we're going to get better outcomes. The most effective is leg strengthening and balance training like Tai Chi. It's so good for elderly patients because it's low impact and it really helps with their balance. And then it has to be tailored. So it's not sufficient all by itself. We really have to tailor it to the patient and their individual risk factors. Another prevention strategy is a clinic. Now, these are harder to come by because clinics are expensive. You have to staff a clinic and, have patients go to the clinic. But when there was a clinic set up and patients were referred there for falls and balance, they had a 50% reduction in falls because it was focused straight on what they were having their risk factors, what their risk factors were, and then targeting those strategies. And of course, nurse initiatives. So that's where you guys come in care coordination. When they've done a study where they looked at nurse-led care pathways for patients who discharged from the ED after a fall, and they found that those patients were they were less likely to be in the hospital a long time. They were functionally more independent 6 months after their fall. They had less ED visits. So you guys know this already because this is your bread and butter. Your interventions, your support of patients, it makes a difference and it changes their outcome. So this alone, warms my heart. What the nurses are doing to help our patients within CHESS, within your value partners, it actually makes a difference and patients are going to the hospital less. So what are those targeted strategies? I kind of alluded to that, where we target the patient for their issues. We want to assess the patient. We want the right population. We want to deprescribe and do some medication review. We have to look in the house somehow, whether it's home health, physical therapy, somebody, because that environment or those extrinsic factors are also key. If we can eliminate some of those, we're going to eliminate fall risk. So we want to look at hazards like their carpets and their poor lighting, and we want to add handrails where necessary to help them to stay balanced. We want to educate and counsel the patients, like, don't wear socks in the house without like the little slip guard. I mean, there's so many things that patients are doing that they're not paying attention to. Having the throw rugs around, having things that are cluttered that they can slip on. Lots of education is necessary, and Shannon definitely gave you guys some good tips on how to do that. And of course, exercise and physical therapy and targeting those patients with specific exercises and physical therapy. So I'm finally going to get to the vitamin D thing, which I've already pretty much described. So there's some miscellaneous preventions, which I thought were pretty interesting that I thought you guys would like to hear about. And vitamin D and calcium supplementation was one of them. We know that it's going to prevent fracture potentially because we're keeping the bones strong, but it also keeps the muscles strong. So it's not only about fracture prevention, but also keeping the patients strong so that they can balance and stay upright. Shoes, I talked a little bit about slips, putting on socks or like slippers. You want a shoe with a thin, hard midsole because like running shoes with a thick, soft midsole, they're more likely to fall. They just don't have that sort of, they don't feel the ground as well through something that's thicker like that. So a thinner, harder midsole is better kind of shoe for someone to prevent falls. All right, so just to summarize, and I'm going to do this, and then we've got a few more slides to go. You want to screen, and actually, Shannon, you did the same thing in your slides. Screen, assess, intervene, and evaluate. So screening the patient for fall risk, using a standardized tool, flag any abnormals so that you can do additional assessments. Then we get to the assessment. We do the gait and balance assessment, medication, vision, home, environment. Intervene, make a referral. And I'm going to talk about that in a minute as what kind of referrals can be made for physical therapy, to the pharmacy team, to home health or community health resources, and then evaluate. Did we make an impact? What were the interventions that were implemented? Was it quick enough? Was it effective? Did they get better? Did their gait or balance improve? And did we keep them from falling at all? Or again, if they were already had a fall previously? So the STEADY initiative is something that was developed and implemented by the CDC, and it kind of takes all of that into account. So in case you guys want to look this up, they've got a great, all kinds of videos and handouts on their website for this, but it stands for Stopping Elderly Accidents, Deaths, and Injuries. It consists of screening the patients, assessing for risk factors, and intervening by using clinical and community strategies. And you want to do this on a patient every year after the age of 65. They also talk about vitamin D in their STEADY initiative, which I thought was really neat. Knowing that there was some studies that showed that that was effective, they also brought that into their initiative. So they say educate about fall prevention, assess if they're taking vitamin D, refer to an exercise program, and then every year check this. Of course, every year also check and see if we're getting better. Is their gait and their strength and their balance improving? Review their medications and home hazards, and then intervene like we talked about. Maybe they need to go to physical therapy. Maybe they need to go to an eye doctor. Maybe we need to send them someone into the home to assess for safety in their home. So I threw this one in here because this is kind of one of my favorites. So this is one of those ways that we can refer. This is a way to refer for help for the patient to get the physical therapy that they need or the home health evaluation that they need. So Safe Strides is something that we've used at the Cornerstone portion of Atrium Wake. I don't know if you guys have heard all those names before, but that I was originally from the Cornerstone group. And so we had a relationship. They are now called CenterWell. They had another name before, but where if a patient had a positive risk for fall, that my system would automatically fire a potential referral. Like I could refer to Safe Strides if I wanted to. So what that is it's a tailored, we like that word, treatment to the patient. We like that because that's the most effective. It includes nursing, physical therapy and occupational therapy. They do identify causes for the fall, which we like because then you can tailor the treatment. And then they do the evaluation for vision, balance. They also review medications. They can recommend if someone needs a walker or a cane, and then they look at the home. They also develop an exercise program for the patient. So y'all know I like statistics. So they, this is their statistics. They say 95% of patients demonstrated improved balance and mobility. 95% of patients showed a decrease in fall risk at discharge. 74% demonstrated improved gait speed, an indicator of risk of future hospitalization. So we did it, remember we did a gait speed evaluation in the office. So they showed an improvement in that. And then they showed a 65% reduction in neuropathic pain in their patients. And overall cost of care was lowered because of that. So this is their bar graphs showing the improvement of the patients when they started on each of these scales and assessment. I won't make you look at this for very long, and how they started and how they finished. And they divided it up by age. So that brings me to the conclusion, and I really do thank you for your attention. Basically, I guess takeaways from my lecture is that I really want you to ask patients about fall risk at least once a year if they're over 65. We want to try to get ahead of things. I like this because why wait till there's a problem? Let's prevent it from the beginning. EFI is a really great way to do that because we can target patients for prevention. We want to intervene when there is a problem, when they do have a risk for fall or have fallen. We want to make sure that we tailor the help for them so that they can get the kind of physical therapy that they need and exercise regimen that they need. And then, of course, we want less falls. So I appreciate your time. If you have any questions, please let me know.